Microphone, that's better. Welcome to this May board for Lancashire and South Cumbria ICB. I'd like to start by thanking members of the public who are observing this board meeting, either in person or online. And I'd like to just welcome Sarah James, the Integrated Place Leader for Lancashire, Central Lancashire, and Dr. Lizzie McPhee, Clinical and Care Leader, who are going to join our meeting later for the discussion at item 5 on patient experience, which is being undertaken a little differently to the usual patient story. There's a slightly different lineup around the board today, a number of board changes since the last meeting. And I'd like to take this opportunity to thank Kevin Lavery, who left us at the end of April, for his significant contribution to the ICB and to the system. I'm very grateful to Sam Proffitt for stepping in as acting CEO, but I'd also like to welcome Andy Knox to his first board meeting as acting medical director, Stephen Downs, who has taken over as acting finance director, and non-executive members Steve Igo, who is our new finance and contracting committee chair, and associate non-executive member Steve Spill. All of these new appointments bring energy, commitment, and significant experience to address the challenges and opportunities we face. For today's meeting, I've got apologies from Roy Fisher, a non-executive member, Debbie Corcoran, non-executive member, Denise Park, partner member for local authorities, and regular participant Dave Blacklog. And I know that Kath is also stuck in traffic, so she'll be joining us later. The meeting is, however, quorate. As always, I do want to maximise our time for discussion, and as board members will be aware from our private meeting this morning, I'm being quite hard line on short introductions so that we have good discussion and we do the substantive work through discussion, questions and answers. I haven't had any declarations of interest for today's agenda. We obviously have the declarations of interest as identified. Are there any additional ones for today? No? Excellent. Thank you very much. So if we can move to the agenda. First of all, minutes. First of all, were they an accurate record of the last meeting? Everyone's nodding. Happy to accept those. Any actions that we missed off the action log, first of all? No? Great. So then the action log, there are 3 actions included. All have updates against and proposals to close. Are board members content with this? Yep. Great, fantastic. So we'll move now to item 5, which is the patient experience. I'd like Sarah O'Brien will give us an introduction on that.
Yes, thank you, Chair. I'm not going to say much other than normally when we have patient story, we hear a video from an individual who shares their experience with us, but we're going to do it a little bit differently today, and actually Sarah and Dr. McPhee are going to actually share with us how they work with a population group and a community, and I think this is really pertinent to when we get to our transformation roadmap later, and also our insights report, really showing how about population health and how our role is around really trying to drive better outcomes for people along a whole population. So I'm going to hand over to Sarah and Dr. McPhee.
Thank you. It's a pleasure to be here today. We've got some slides that I think are just going to come up on the screen. There we go. So I suppose the first thing to say is we're not going to give you a patient story. We're going to give you a story about what we're doing in our population of Preston. And it's not to say that it's not really important to follow our patients and truly understand how their experiences have been, but actually we've learned from the work that we've been doing in Preston that we can have a far greater impact working as a group of organisations and looking at that on a whole community rather than individual patient stories. So that's what we want to talk to you about today. And I'm going to talk to you about it in a number of shifts. So the first one is from doing to working with. And the first way in which we've changed some of the ways in which we've worked within Preston is to move from being a group of organisations to a group of system leaders working together through system partnership. Over the last 2 years, we've established the Preston Health and Wellbeing Partnership around the District Council boundary, Preston City Council, working with public sector partners, working with VCFSE, and comes together to talk about not what our rates look like at A&E, not how we can keep people away from the front door, but about what matters to our communities and their health and wellbeing and how we can support them to keep healthy. We've got some great leaders around that table, including elected members and others who've really pushed this work forward, and we'll talk a little bit about some of them as we move through. One of the first things that we did as a health and wellbeing partnership is to really understand our population health data, really understand our communities. And we started with the areas of St Matthew and Ribbleton, which are on the screen in red. Some of our most deprived wards in Preston. And just to give you a bit of an insight into this, if you're not as close to Preston as some of us, in St Matthews and Ribbleton, men will die 9 years younger and women will die 5 years younger than in other parts right next door to them in other wards. They're more than twice as likely to die from preventable disease. And they're 2.5 times more likely to die from circulatory disease. Yet apart from some of that, they're less likely to die from cancers. And when you actually look underneath that, that's not because those residents are healthier, it's because they don't go for screening. It's because they're not subject to and enabled to access screening in the right kind of way, and because we don't pick them up through the data. And we've only discovered that through talking to our communities. So we've worked really closely with Preston City Council to have community conversations in St Matthews and Ribbleton, showing them some of this data and talking to them about it. And when you talk to them about it, they don't talk about the rates of CVD, they talk about crime, which is twice as high as in the ward next door. They talk about food poverty and their ability to access food, which again is twice as high as the ward next door. And they talk about older people living in poverty. They talk about child development issues since COVID and the fact that children are arriving at school not ready to learn and not really ready to look after themselves in that way, shape or form. So we've got a long journey to go on with our communities in St Matthews and Ribbleton, working alongside our other partners. But whilst we're having those conversations, we wanted to do some tests of change. We wanted to think about how we could really start to work differently as a group of strategic leaders and system partners across Preston to look at if we were to really commission services differently with a population and public health lens, what might that look like? So I'm going to talk to you about 2 tests of change that we've done so far in Preston. So the first one is, and I'm smiling at the photograph on the page, which I will explain, which is one of our wonderful GPs, Dr. Jeremy Han. So the first one that I want to talk about is the Preston Rough Sleepers project. So in terms of this shift, this is really looking from reactive management to proactive support. So how we can really undertake anticipatory neighbourhood-based care in Preston. As well as looking at a whole community, we also wanted to look at a population group. So how can we commission services differently for a specific population group? And as though some of you may know, we do have a group of rough sleepers in Preston who there have been a variety of different pilots and approaches to try and get them support and access to the right health services, which haven't always ended in the right kind of place for them. And one of our local primary care networks, led by Jeremy Han, who's on the screen, who's the clinical lead for that primary care network, has worked really closely alongside us, alongside a BCFSE organisation called the Fox Street, and Preston City Council have been a huge partner in this, to look at how we can support some of those communities to access health services. What we were finding is that those people who were living on the streets were often turning up to ED for issues. They couldn't get registered with the GP. They didn't feel they was wanted to access a GP surgery when you talked to them because they didn't feel they were clothed appropriately. They didn't feel they smelled right. They didn't feel they were able to sit inside a waiting room. So what we've done part of this project is to locate a GP surgery within the day centre that people attend to get the breakfast, where they go to get support with benefits, where they go to get support with employment. And Jeremy Han is the GP, and his practice and some of their practice nurses are now running 3 clinics a week out of that centre, working alongside other partners. So we have mental health provision in there from LSCFT, we have public health provision in there from drugs and alcohol services, we have social care provision, we have outreach from our community and district nurses, and we have in-reach as well from Lancs Teaching as our acute hospital to support some kind of the more trickier cases. Since development of that, so we've had a pilot project running from March. We've now got 83 patients who are registered with that practice working out of that day centre that didn't exist before. We've had 450 clinical consultations, including things like wound care, screening, vaccinations, immunisations, things that will keep people healthy, as well as them coming to us with issues. And actually, we're pretty sure that we prevented 98 people from going to the emergency department. And that wouldn't have been the right place for them, and it wouldn't have been the right place for them to go in that service either. So that's an example of some work that we've been able to do around a particular population group. The next shift that we want to talk about is a shift from treatment to prevention and hospital to community. And I'm going to hand over to Dr. McPhee.
Thank you. Okay. Ooh, hello. So hopefully that's picking up. Yeah. So I'm consultant rheumatologist as well as being one of the clinical and care professional leads. And I'm really enthused to talk to you about this project that we've done. So I think it's really important to acknowledge that this is politically at the moment really important. We know there's this huge emphasis on shifting work out of hospitals into the community and to look further upstream to what can we do as far as prevention. And you may or may not recognise the leisure centre there on that photo, which is our leisure centre in Preston, which is Westview, run by GLL. And we all know that our leisure centres are really struggling. People are not necessarily prioritising going to leisure centres for lots of different reasons. And we know that they're struggling to get people through the doors. And these are great opportunities with fantastic facilities. And if we don't use them, we're unfortunately going to lose them. So we thought, well, what can we do to support our leisure centres, but more importantly, encourage patients who we're seeing who would really benefit from having some of those fears and worries about engaging with exercise. What would it be like to co-locate some of our services there and help to dispel some of those myths, build confidence, remove that fear of stepping out and engaging with physical activity. Not all physical activity has to be done in a leisure centre, but if we got groups into those settings and started to build people's confidence, then would that promote a sort of greater vision for the future for those individuals with respect to self-management? Some may then feel less fearful about going to those environments because they've just had the opportunity to step into those environments with that support around them. The other thing to really highlight is that we're struggling also for pressure on hospital estates. So we've been wanting to run a number of groups from our services, but we don't have the group settings, the rooms in which to deliver those. You know, we've got clinic rooms, but actually the places where you can bring together a group of between 15 and 20 people to exercise are very limited. And then there's the struggles. You know, if you deliver these interventions on a hospital site or in an NHS setting, people have got those worries about how they're going to park the car. So what turns into, you know, an hour's visit to attend a group becomes 2 or 3 hours for some patients, and also thinking about the carbon footprint. So we wanted to demedicalise some of these interventions, to take away some of this, to start to help people move towards that self-management, those longer-term goals, remove some of that fear. So I'm going to step into my place of fear now and get you all up and moving. So what we did was we looked to deliver the Escape Pain programme. So I'm going to very gently get you on your feet. I have brought my exercise bag. Any of you who have teenagers will know that this is now the standard kit bag for any teenager. We've got our tins of beans, we've got some ping pong balls, but I'm not going to get any equipment. But what I'm going to just get you to do is to do some, not going to be too strenuous, Chris. I'm going to get you to do some very, very simple core. We thought about squats, I was banned from doing squats, so we were worried about the chairs. So we're just going to get you to do a simple thing which will help to strengthen your core, which is to stand on one leg for 30 seconds, and then we will ask you to change and stand on the other. If you need to balance on the table, that is fine. If you need to take your shoes off, you need to push your chair back, equally fine. Okay, and Sarah's going to be my timer, so I'm going to sit back down because I can't with the mic, sorry. So the Escape Pain programme is a validated exercise programme for patients with lower limb osteoarthritis affecting hip and knee. It encourages patients to carry on their normal activities, to get more active, to manage and understand their symptoms, and to continue to exercise. And we have permission of all the patients on screen. These are people in the group who are taking part, who wanted to share their experience. So who? I work for Lancashire and South Cumbria Foundation Trust, and we work in partnership with Senti, who deliver our MSK and physio groups. Just 30 seconds up. 30 seconds up. You can swap legs. Okay. So what we did was move out our physio groups into these community settings. We weren't able to deliver these groups because we didn't have the estate. So this was something that was new to us. So where have we delivered them? We've delivered them out of 3 leisure centres across Chorley and South Ribble. And we've worked with Chorley and South Ribble Council, delivering them out of Leyland Leisure Centre. You're off the hook. You're done. Well done, everybody. Thank you. And also in Chorley Westway at the Hub. So we had, if you like, one set of agreements we had to make with Chorley and South Ribble Council, and another agreement that we had to make with Westview Leisure Centre, because the leisure centres, as I said, are commissioned and delivered slightly different across those two councils. But we were really keen to deliver them out of different sites, because patients, you want to encourage them to go to their local leisure centre. We want to make sure that we're not driving health inequalities by people not being able to engage with groups because we only deliver it from one site. So there's lots of comments on here. Everything that is written in black is feedback from the patients, and everything in purple is feedback from the clinicians. And what I would like to highlight is that comment in bold. So that's from a patient of ours, would highly recommend others who are transitioning from physio to self-managing. So they really saw that on-site, where we were going with this. And there's another comment there from one of our clinicians. They so liked the leisure centre, they'd never stepped foot in Westview. They signed up. And actually what's happened is because of their enthusiasm, because of the course, we're finding that patients are actually taking the offer of signing up. So it was really nice. She's had a couple of patients from groups who've signed up to become members of that leisure centre. So what's next for us? So we recognise that at the moment we only deliver the groups to certain populations who are English speaking. So we're looking to see whether, because of the people we have trained, whether it's going to be possible to deliver it in Urdu and Gujarati. That was Google Translate, so I hope that's correct. Then we are looking at other groups. So we want to set up a shoulder pain group and a back pain group. And we're also recognising that we deliver these at the moment at times when the leisure centres are quiet, but those are during working hours. So we're looking at an evening group and possibly a weekend group. We've also accepted that there's lots of other things that the leisure centres offer. And at Westview, they have physical activity coaches who are trained up with physical qualifications for managing people with long-term health conditions. So we're looking at how we can partner with their scheme, the Healthwise, to promote that. And we're really keen to be stretching out and looking at other services. So we're having conversations at the moment with Lancashire Teaching Hospitals for some of their groups delivered from orthopaedics, their pain services. And we've also been having discussions with talking therapies who've been really struggling for estates to deliver groups out of. So I'll hand back to Sarah.
Thank you, Lizzie. So I suppose that's kind of the end of the story that we want to tell you this afternoon. But in conclusion, I think from our perspective, it's not a patient story. It's a number of patients. It's a group of communities. It's a group of individuals who have similar characteristics, who happen to use our services in the middle of Preston. It's a group of individuals coming to that leisure centre. And we've done what we've done through bringing partners together through collaborative working, but actually, imagine if we had the opportunity to do it on a much bigger scale. If we could commission services properly for our populations, looking at what they need, we could do so much more.
Thank you. Thank you, Sarah and Lizzie. I found that a really inspirational start to the board meeting. And it grounds us in what we are all here to do, really here to do. You talked about population health, you talked about inequalities, you talked about keeping people healthy, so not needing so much healthcare, or at least managing themselves, supporting people to self-manage. So thank you very much indeed. I found that really, really good. And of course I did visit, which was even better to see it in action. Questions, thoughts, comments? Yes, Asim.
Thank you for that. And I think again, Emma, this encapsulates what the ICB was set up to do. So to plan our health and care services around the population. And Sarah shared some of this with me previously, and I think there's more people now enrolled on this. And at that time, I think you shared that it was there was 44 avoidance of hospital admissions. And if we extrapolated that for the year, it'll be about 120 hospital avoidances for that small group of patients. And when I come onto my performance item, we will see how much demand is increasing in our services. So this is not, for me, a good thing to do. It is a must if we want to control the demand in our services and transfer care closer to the home. And I can confirm the Gujarati and Urdu translation was correct.
Thanks, Asim. Chris.
Thank you both. I think that it's just so inspiring, isn't it, what you've just talked about there. I suppose my question is, I didn't know that was all happening. We've got bits, I know Pastor Mick, Church on the Street over in Pennine Patch. Where else is this happening, and how do we know what is happening? How do people know to refer into these services? So I've been really fortunate to be on the population health programme, which I think you two are both on as well, and Andy runs that with a couple of other people. And part of that was to sit in a GP. So I sat in with a GP this week, and he referred a patient to a leisure centre for aqua aerobics instead of a referral into physio. So this is happening, and I just think, how do we capture it? How do we pull this all together? We talked earlier this morning about neighbourhoods. This is neighbourhood healthcare and social care together. It's just fantastic, but I think there's probably a role for how do we pull all this together.
Yeah. I've got you. Asim, can you? How can we? And this comes back to this. You've been talking about this for a while in terms of how we use our performance report to start to look at how we're doing. Absolutely this.
And I think Sarah and other colleagues have seen the work we have done around high-intensity users, which has been presented to numerous places. So what we have, Emma, is real low-level information. So all of them patients or people, we can see all of their interactions with our health and care systems and what their diagnoses were. And what we see for that group of individuals, that many a time they're going into A&E and they're coming out even without any real intervention, because it's sometimes the warmth of the A&E centre they need. So, and I've always made this argument, there isn't a shortage of data. It's what we do with it, and what we've demonstrated here is this team has taken that data and then had some real good interventions that is making a difference. And it comes back to Chris's point. We've got this data for all of our populations and our places. It's the interventions then we need to put in place to do population health, commissioning population health level intervention.
Thank you. I know you're wanting to come in as well, Andy, and I think I'll bring you next because I suspect you'll follow on from that.
Yes, thanks. I mean, big broad smile across my face. I love the work going on at Foxtons. I love all of this stuff. And I think your last challenge to us, Sarah, was really spot on. How do we scale and spread this? And I think what's really encouraging to me sitting here as acting medical director is we already are. And actually, it's very much in our future roadmap of what we're building over the next 5 years. You know, our vision is really clear as an ICB that we want to have high-quality, community-centred healthcare by 2035. And we are on the way. So beautiful to hear a story from Preston. But actually, the great news for the board is, and a sense of assurance is, we could have told stories today from Barrow and from Blackburn and from Burnley and from Hyndburn and from Fleetwood and from Morecambe and from Lancaster and from Blackpool. And maybe we will a bit later when we hear Neil's paper and we hear what I'm going to talk about later on. And actually where we're moving towards very swiftly with our new ICB blueprint and our sense of strategic commissioning is this approach to population health. What is the data really telling us about where the inequalities are in our communities? How do we then go and listen to those communities, suspending the fact that our data doesn't tell us everything and they're going to tell us a different story themselves? And then how do we together as partners in those neighbourhoods and places join our resources and forces together with those communities, not doing something to them, but to transform the way care is happening? And the great news is it's happening in loads of our places now. What we need to work out now is how do we take the beautiful small projects and scale and spread them so that those things happen everywhere and we see the real community transformation that we want to see. And we're on the way. It's going to be part of mine and Craig's way that we commission into the future. But a beautiful story. Thank you for telling it and inspiring us. And the good news is it is spreading already.
Thank you. Thank you very much, Andy. Tracy.
Thank you. Yeah, a lot of what I was going to say has already been said, but thank you both for coming. I want to just pick out a couple of themes, really, that have come out in what Andy and Asim have said. The first one for me is about the importance of taking things to communities, and and it absolutely runs throughout all the work that you've been doing. You haven't expected people to come to you. You've taken services out into the community. I think that is the future of the way we do things across health and care. The other theme, really important to me, I used to run a social enterprise in Ribbleton that it was a social business that employed ex-homeless people and provided accommodation to them. And one of the key things that you talked about in your presentation was around stigma and fear. That was a massive, massive barrier for the people I used to work alongside. And I know that you all know this, but I just really wanted to say that because the work that the Foxton Centre do and Emmaus in Ribbleton is absolutely incredible to reduce some of that stigma for people and move people out of those circumstances and into much more positive lives. And I think, you've aligned the health side of it with that, which I think is a really, really incredible move for those individuals who find themselves in that situation where they just wouldn't access things because of the way it makes them feel. I think I absolutely agree about all the things that are happening across our system that are really doing that shift into community. Just a word of caution really around, let's not think that we can lift and shift what happens in Preston into other areas. Let's be really, really cautious as we commission these services to ensure that they're commissioned based on that population data, on what we understand about those communities, and let's not try and cut corners and think, oh, actually, if that works in somewhere like Ribbleton, it's probably going to work in a similar community like West End in Morecambe or Claremont in Blackpool, because often our experience of our sector VCFSE work is that actually it needs nuancing, it needs different partners around the table, and it needs quite a different approach sometimes.
Thank you. Thank you very much, Tracy. Sakthi.
Thank you, Chair. Really encouraged to hear this. And as a local director of public health, I really welcome, and partners will welcome as well, to have some systematic ways of collaborating. Just balance to what we've heard. Whilst all great things are happening, they are happening in spite of us not having a structured approach for commissioning services for our populations. And a test for that would be to look at our commissioning plans to see how they actually feature. And I suggest they don't, for the short term anyway. It is in the roadmap, and we all need to get behind to make sure it's a reality. And another sense check here is, whilst some of these projects have proven their worth, some of the funding, for example, the homelessness project, actually is not going ahead as we thought. So there needs to be a reality check in terms of our ambition and rhetoric and actually what's happening on the ground. And that, I suggest, would only come not through repeated tests of change, but embedding this in our commissioning plans, our estates plan and workforce strategy, by systematically shifting therapists and OTs and wellbeing workers into leisure centres, not having double track of estates plan, but actually have one plan for a neighbourhood or a city or a town. And that's, I think, is the big prize to seek as a board and as a system of partners. Thank you.
Thank you. Thank you, Sakthi. And I think you might touch on this when you, yeah. So that you're absolutely right. And I've got Julie.
I was just coming in on Chris's point about coordination. I think we've got so much going on in our communities, and actually our integrated neighbourhood teams are a great resource for developing their own digital directories. And we see that across the Bay where I am, is that actually our communities know there's lots of resources and they can't find them themselves, so they are coming together to use digital. So I think it's just bringing those two things together, isn't it? The shoots are coming up and we need to maybe water them, isn't it?
Thank you. Thank you very much. Yeah, Aaron.
Thank you, Chair. I think there's a challenge for us as a board about the tension between centralising strategic intent and local development and local autonomy to make these kinds of decisions. So hearing with fascination kind of that conflict of budget alignment, commission intentions and roadmap, and then the locality teams working with the data with communities and what works for them. So there's just something to consider about how do you create enough of a central function and a strategic roadmap that are gives a bit more permission and knowledge and training for local communities to do this themselves, because we're not going to be able to strategically commission all of this. So there's just, when we go through the commission intentions of the roadmap, I think it's writ large, but we can't systematise and strategically commission everything. It's about how do you put this autonomy back into local communities with a bit of evidence, autonomy, and some examples of what might work so they can do it themselves.
Absolutely. Thank you. Sam.
Thank you, and what a great presentation. Thank you very much for that. I think, for me, I'm going to talk a bit, when I come on to my bit, about the operating model for the future, which will really support this, and I think it's the right direction. And as Chair has said, I think this touches on everything that we would want to aspire to in terms of our aims. It has everything in it, the health inequalities and outcomes for patients, but it's actually cost effective longer term. It's very hard to prove some of this upfront, and the evaluation of something like this is really important to keep building. But I think the beauty of this is it's taken something that truly looks at what are the needs of our population, and then changing what we need to do to support that. And it's a great example, and I think Chris's point is, this is happening. It might not be the same project, but it's different things that are happening right across our patch, but we don't really look at that in a way that we should be looking at. The new operating model will help us to do that. But one of the big things for me that really makes this work is you know, and the passion that, you know, and I know, Lizzie, we've been doing sort of engagement events before, but your passion, and Sarah, your passion and your commitment, your values in what you're doing is what's driving this. You know, this doesn't happen by itself. It happens because of people like you really making this. So I just want to give you a massive thank you, and to all of the teams and all the people that are doing this right across our system, because there's lots of examples of this. Because if we can crack this and get it right and look at what our population needs through a different lens as we go forward, then we will make a massive difference to our population. So just thank you, and a great story, and thanks for giving me 1 minute of exercise anyway today. So
Thank you very much indeed. You're more than welcome to stay, and because actually some of the board agenda later we'll touch on this, but I do understand you may have better things to do. So thanks very much indeed, both. Okay, so we're now moving on to the my chair's report. Since the report was written, Sam and I and the chairs and CEOs of Blackpool, Lancashire Teaching Hospital and ELTH attended a Recovery and Support Programme entry meeting with NHSE, which is one of the formal steps that is part of the Recovery and Support Programme that we are in. There was an opportunity for us to reflect on the progress that we've made so far and the work that is yet to be done to enable us to meet the undertakings that we've signed that I referenced in previous board meetings. And we were very clear about our ambitions, about the progress that we've made, and our ambitions to exit the Recovery and Support Programme as soon as we possibly could. The meeting went well. We've had good feedback on it. And I think what came through to me most powerfully was the way in which we talked as a system, perhaps more than we have done in the past, and the way in which we owned what we needed to do, and understood what needed to be done, and that made for some positive discussions. And if I sort of now move on to today's board, I think some of that progress is evident in some of the papers that we've got. We have improved our run rate over the last quarter of last year, both within the ICB and across the system. And that allowed us to reduce our overspend for 24-25 it was still eye-watering, but over the really eye-watering figure that we were talking about back in September, October. We've got much more robust plans for the coming year and beyond that give us greater confidence in our ability to deliver. And Stephen Downs will present where we've got to later on in today's agenda. We've progressed our transformation roadmap. It's been mentioned a few times in today's discussion even so far. And that sets out some of the key milestones for delivering that vision of a high-quality, community-centred health and care system. This is an agenda item later on. I'm really looking forward to some substantive discussions in that as we work through it. Before that, we have a paper from Neil Greaves, our Director of Communications and Engagement, that describes how we listen and use what we have learnt to develop the insights that underpin those plans. We started to embed the new terms of reference for our committees, which we brought to the last board, and that's providing greater focus on delivery, both of quality and efficiency improvements. And it's imperative that our board committees, subcommittees, are able to provide this board with robust assurance. So I'm monitoring that very carefully with committee chairs. And as Sam will describe in her report, we're making very good progress with the work around restructuring the ICB. And I won't say any more about that because I know Sam wants to talk it through. But that, again, links very strongly to the discussions that we had around the patient story. Finally, as the transformation roadmap will highlight, nothing we want to achieve can be done alone. And I know that Sam and the whole executive team are working to address some of the issues that have hindered our ability to really work well with partners across the system. Much of the work we're doing to streamline our governance and grip is key, because making the ICB more effective as an organisation will undoubtedly strengthen our ability to be a good partner. There's still a lot to do, a great deal to do, but I'm increasingly confident in our direction of travel and that the improvements that we're making now in governance, grip and organisational design will enable us to deliver our plans, ensuring that we better serve the needs of the population of Lancashire and South Cumbria. Thank you. I'm very happy to take any questions on the paper, which is fairly functional, or indeed anything else. No, in which case I'm going to move to Sam.
Thank you, Chair. And good afternoon to everybody. I suppose I want to start by really thanking everybody for the incredible amount of hard work that's going on behind the scenes. And, you know, it's a really challenging period. We're in a massive period of change. And despite that, I'm seeing every day people working extremely hard to try and make a difference. And I think one of the reasons we're seeing that is because I think we can see that we are turning a corner and we're starting to see that progress that the Chair has just outlined, and we were able to describe that yesterday. So just a massive thank you to everybody that's really working hard at the moment. And I suppose I want to give my commitment while I'm in this really privileged position, and it is a really privileged position to be leading the organisation for whatever time I'm going to be here, to make sure that what I really want to do is bring the leadership and clarity to try and navigate us through what is going to be quite a bumpy ride the next few months, really. And, you know, I think, you know, that's exactly what I'm going to try and set out to do. And the new operating model that we keep referencing, what is that? You know, it's going to bring a period of uncertainty for staff because we're being asked to reduce our costs as an ICB by 47%. And, you know, that's huge. And we're working closely with teams. What's going to be important, you know, we've come up with a set of really clear values for the organisation. We have to do this with those values at our heart. And they are, you know, working with compassion, integrity, respect and inclusion. And that's going to be really, really important as we go through this. And I'm not saying that as a you know, that's a tick box sort of explanation of we've got a set of values. It's going to be really important that we live those as we go through this next period. And I want to bring that clarity and listen to our staff and work with our partners to create the right infrastructure. We have an opportunity with this as well as a challenging period to get this right. But we'll only do that by properly listening and engaging with everybody, all our staff and our partners. So we've been working to apply what's come out nationally as a blueprint. It isn't a prescribed structure, it's a blueprint for ICBs. And the plans are starting to emerge. We've got to submit a plan by the end of this month, which is the end of next week, and have arrangements in place by December. But when we will embark in June on a period of consultation and engagement around those plans that will engage all our staff and our partners in doing that. And it's going to be a significant change because the blueprint, though, does build on our vision. And actually, for the future, it gives us an opportunity to reset ourselves in line with that vision. And the stuff we've just been hearing about is going to be at the heart of that. So the main focus for the ICB going forward is going to be as a strategic commissioner. And what does that mean? It means that we have got to ensure that we understand properly through good analytical data, good listening, exploration, and proper intelligence, we need to properly understand the needs of our population, building on the neighbourhood models and commissioning the right services. And they will be different in different parts of our patch and our geography, because we've got to meet the needs of those local populations which are pertinent to each area. So it is what we were set up to do, in fact, really, but actually this takes it a step further. So despite the challenges, it does really focus in on what we're here to do. So this will facilitate the changes we need to see to focus on community out of hospital models. It'll be looking at how we provide services in the right place and shifting more towards prevention, as we've just heard before, rather than just treatment. That's going to be at the heart of what we're doing. And it'll also enable us to transform using digital capacity and capability. And we know from certainly the engagement I've been involved in, we've heard it here at the board, that digital enablement is so important to many, many people and seen as a key barrier at the moment, but it's also a massive opportunity. So the key changes will be to move away from an oversight role. We've had this sort of oversight role of our providers in the system, and also that won't move completely away from that, but it will remove layers of duplication around assurance in the health service that we've seen at multiple levels, and focus us very much as that commissioner thinking about our population. So as part of us entering this sort of the intervention phase, we'd already started work on looking at what is the right operating model for our commissioning. We've heard today, we know commissioning doesn't work in the way we need it to work, and we'd already started that. I think when we look at some of the challenges we've had, and when we went into intervention, yes, we hadn't delivered all of the plans we had to do, but neither were we set up to do that. And so that's why a focus on commissioning has been a big part of our intervention journey. So it's not like we're starting from scratch. We are starting with some really good information and some good work that's already been done. So what we're going to do is now use the blueprint to help us land that properly with our structures and our models going forward. And we've heard today through that patient experience session, which was really powerful, how the local population focus and working across providers can make a real difference. And we don't just mean health providers. This is about wider determinants of health. This is about all of our partners in all sectors, including the voluntary sector, the voluntary faith and social enterprise sector, and all of our other partners and local authority. It is about working with everybody. So today on the agenda, you know, we've talked and Chair talked earlier about the roadmap, and that is really important. That is being driven actually from some of where, you know, some of the information that we have about what's really important to our populations, and it's going to set out, and Andy's going to take us through this, but it's going to set out key areas that we need to focus on that will then inform our commissioning intentions going forward. And you're going to see today that some of those really important areas are things like end of life, frailty, and we've also agreed, and it's outlined in my paper, we've agreed the local enhanced services for primary care, which again support that real community focus and that left shift. So all of these priorities support us to remove pressures and demand that we see in the urgent care pathway, which we know again is a really big problem for us, a really big pressure, not just from a cost perspective, more importantly from a quality perspective, and we've talked about that at the board before, but we've really struggled, haven't we, to execute the plan to deliver that. This will really help us to do that. And we have seen green shoots, which is great as we've entered this intervention stage. And you know, as hard as intervention is, it's actually helping us to start to really turn a corner. And I think those green shoots are showing that the grip and control, having robust plans, the financial pressure that we know has been driven by the way we're configured as well across the system. And we're seeing that our run rate is coming down. We are seeing some really positive movements. And, you know, what's really important is that we start to really address that underlying deficit that we've had for over a decade in Lancashire South Cumbria, because it's a distraction from what we're trying to do. We need to sort that out so we can concentrate on the long-term benefits. We're going to be expecting to hear or to receive a 10-year plan that we need to work up over the summer, and that will drive this role. And I mentioned again in my report about the work that's going on around the ICP. There's a real opportunity with the ICP to start bringing our partners together and carefully consider, and we're going to hear a little bit about that as well, around the 10-year plan, and work closely with all of our partners to execute those changes for our population. And it will mean that we want to co-produce this with partners. And I truly mean co-producing. I don't mean having a chat and telling you what we're doing. This is about us getting around the table and doing this together. And connecting the ICP partners on that 10-year plan is going to be an important part of that journey. So the final point from me, I guess, is that we've got an opportunity through this change to really listen in this next few months to our staff, our partners and our public. And we need to do our best work here to get this right. And we're going to hear from Neil today, as the Chair's mentioned, around the sorts of levels of engagement we are already doing. What's going to be really important is we really have a feedback loop on that, and we're really listening to that, and it's informing our plans. Because if we're going to be landing these plans the next few months and working them up, we've got to make sure that we've listened. So despite the challenges, I guess what I want to say is it's also an exciting time, and I feel incredibly, conscious that this is going to be difficult for many of our staff, and, I want to keep everybody briefed and bring that clarity as quickly as possible so that we can get on to really sort of making sure that we've got those clear plans and we can start to deliver our aims and our ambitions for Lancashire, South Cumbria, and that we can get better outcomes for our population. The only other couple of points in my Chief Exec report today is there are some good examples, Derry House, for example, around some of the shared care, the care record that we've put in there. And I know I want to go and see some of these places because they look fantastic. And I think it's really important that we understand the small changes we can make using digital to really make massive impact, which is really good. And then there's the information there in the report around My Wishes, which is a great website and an opportunity to really improve some planning in end-of-life care. And I think that's a really great initiative that we've got going there. So other things, read it, and I'm happy to take questions. But I think that's all I really wanted to say. Thank you.
Thank you. Thank you very much, Sam. Any questions for Sam, either about the report or about her verbal update? Yes, Sakthi.
Not a question, just a comment, just to appreciate the level of stress and anxiety in staff, and as partners and as people that have gone through this a number of occasions over the last 10, 15 years, we only know too very well how unsettling this can be. And I just wanted to thank you and the leadership team for what you're showing to the staff and the rest of the partners, and here to support you along the way. Thank you.
Thank you. I suppose I just would want to add that we've got, and we saw it today, we've got some real talent, and a big part of this is going to be also the work we're doing around skills audit and understanding where some of that talent is to make sure as we re-land all of this, we give real opportunities to people as well. So it is really important, but thank you for that, Sakthi.
I'd echo that, thanks. It is very, very difficult, and we are putting a lot in place through Debbie and others, but it isn't easy. Okay, I think, therefore, we will move on to Working with People and Communities Insight Report. Neil.
Thanks, Chair. So just as a way of introduction to this paper, I did want to recognise that the report really summarises work from colleagues across the organisation, but also across partners as well. Some of those we've heard this morning, but also things like our population health team, our cancer mental health team, primary care, and our place teams as well. So I think real credit needs to go to some of the staff across the organisation who are working with people and communities. As this is the first time this paper has been to the board, and this has been looked at in the Public Involvement and Engagement Advisory Committee, section 2 and 3 talk about more of the processes, the strategy, some of the legal duties that the ICB has around engaging and involving with communities. So that's included in there. I wanted to point out in section 3 some of the approaches that we've got around engagement involvement I think are really important, particularly some of our work with Local Health Watch and partner organisations. So even last week I was working with our Local Health Watch organisations to align their work plans with things like our roadmap and our priorities as an organisation as well, so we get best value out of the work that our partners do. And also in terms of our voluntary sector partners as well, much of the examples that you see in the report are working with some of our really good voluntary sector organisations on the ground who have got some of that best connection to some of our kind of diverse and more marginalised communities as well. So I think that's really, really important. In section 5, we've got some key themes that we hear consistently across public engagement over the last 2 years. And I think it's really important, as Sam just mentioned there, that how we embed those in our kind of future commissioning work and absolutely meets that kind of ambitions that are in the model ICB work is really important as well. So, and one of those examples that I did want to point out links to something we were talking about earlier. So the 4th bullet point down in section 4.1 are a number of videos of best practice sessions from our population health team. So some of those examples where we said, where can we hear about them? I would encourage people to watch those videos. They're absolutely examples of partnership working on the ground on that webpage, videos of health and care professionals and partner organisations coming together to look at how do we demonstrate some of the impact that Sam talks about. So I would point people towards that. And then finally, before I take any questions, that there's also some of the work in this is very much around the work that we do with our public and public engagement. We also work really carefully with a number of partners, so our MPs, our kind of politicians and scrutiny committees and health and wellbeing boards as well. So they have an important way of helping us make sure we hear some of the voice of our communities. So not really recognised in the report, but also really important work that we do as well. So happy to take any questions. The recommendation to note and kind of see some of the work that's going on across the organisation, and happy to take any questions.
Thank you, Neil. Yep, seeing lots of hands. So I've got Aaron first, and then Jane, then Chris, then Tracy.
Thanks, Jan. Thanks, Neil. So the report's really comprehensive and gives a good insight into the breadth of engagement activity we do. I think some of the previous experience when we talk about communications and engagement is going back to those groups and asking the question, so do you feel heard? Is there any change you've noticed as a result of the feedback you've given? So this feedback loop and being really clear as to how that feedback is helping shape change, I think is an important next step for us. And one of the things we talked about in an earlier meeting is we do focus on things like quality impact assessment, equality impact assessment before we agree proposals or strategic changes. I'm just wondering if there's something we could do to be a bit clearer on the feedback we've heard from the engagement events and how they've been reflected in the proposals, or almost as importantly, why they haven't and why that hasn't been reflected. I think that'd be an important part of this next stage of engagement with our communities.
I'll take a couple and then I'll come back to you, Neil. Sorry, Jane, and then I'll come back to Neil.
Thank you, Neil. I think this is a great report, some really good examples of work going on. I was looking at this through a strategic lens now, particularly in relation to health equity or health inequalities, and thinking that often the most disadvantaged people are the people with the worst health outcomes are the hardest to reach in terms of engagement. And there's not just one reason for that. It's almost like, in marketing terms, almost doing a kind of marketing segmentation to understand the reasons, which might be anything from trust, lack of access to IT, not having English as a first language, cultural barriers. There's a whole range, aren't there? But I was thinking perhaps going forward something for you to reflect on in relation to the strategy and the priorities is how you would understand that better and actually be really quite targeted in different target populations within that engagement strategies. Because what will work for one group will not necessarily work for another. I'm sorry, I don't mean to be telling you to suck eggs, but just something about a strategic lens on this. If we're going to address outcomes for all our population, we kind of have to do that bit of thinking, don't we?
Thank you. Two good questions there. I'll let you answer, and then we'll carry on.
Yeah, thank you. So, Aaron, I think partly some of the challenge we have when you hear some of the work that Sarah and some of our other teams are doing on the ground, when we start to co-produce, sometimes it's quite difficult to get some of that example of so what, or some of the examples, because we've actually developed it in the right way, which is actually to co-produce and actually come up with something which has had them at the heart. But I think some of the examples, like videos that I talked about before, are really good examples where actually on the ground it's working directly. So and Andy might want to comment on this, but certainly the population health team are working absolutely with some of those communities, and the feedback loop is actually part of demonstrating some of the work that we do. And I'm also on the Population Health Academy, so some of this is running through what we do. But yeah, absolutely, that feedback loop is really important, and sometimes they can be very specific pieces of work. So sometimes it might be about a specific GP practice or some of the decisions we make. So sometimes it is easier to be able to demonstrate how our decision making has been really influenced by engagement. Sometimes it's more about the co-production of how we provide things on the ground. So but I do think that is really important. Section 4 try and describe some examples where we've done that, but I recognise the more we strengthen some of our commissioning, the more we'll be able to kind of be able to realise that through. And Jane, just on your point, I absolutely agree. The majority of the work that we do is absolutely on the ground, working with some of those communities. Language barriers is probably the number one thing that we hear in a lot of our areas, or even just the ability to kind of understand or communicate effectively with some of those groups. I think we do quite a bit of that segmentation already, and maybe if it doesn't come out in here, but if you take, for example, some of the work that we're doing, particularly around understanding kind of access to cancer and early diagnosis of cancer that we're doing with Spring North, they've worked with around about 180,000 people since January. That's absolutely on the ground engagement in different areas, understanding, what is it like to actually access cancer in one area or another, and as you say, language and attitudes are the key things that come up. And it's very much looking at some of the different pieces of work we're doing and what are we trying to get out of them. But yeah, I can assure you that segmentation work does happen, and it's about helping to support some of that decision making. Very, very different information we get from different areas as well about some of the important things. I think it's section 5 of the report gives an idea of consistently, strategically, when we look at all of the engagement work that we do, certainly that access to services, the challenges people have with digital, language barriers as well are kind of really key themes that come up consistently, but in each area they're slightly different, some of the issues of that, but it's helpful for us to know what those concerns are.
Thank you, Neil. I've now got Chris.
Thank you, Chair. Thank you, Neil. It's really good to see the report at board. I think it gives a whole another lens to the work that the ICB is doing. Just 2 questions, if that's okay. One on section 3 in the table there, and it's good to see that breadth. But from an MP, a local MP, how are we engaging and making sure that they're involved with some of these conversations? And then in section 5, I thought it was really good that the population, the consistent theme is around addressing mental health and well-being in general, and especially in some of our vulnerable communities and groups. How do we then triangulate that back to providers, be it NHS or non-NHS, so that we've got that cohesion between what you're hearing in community engagement and what we might be providing, and how that provision needs to be tailored to what you're hearing as well? That's okay.
Sorry, last, Tracy.
Thank you. Yeah, like Chris, I really welcome this report coming to board. I think it gives it a completely different opportunity for us to discuss it in this space. So thank you, Neil, for that. Again, really welcome the insights that are within this through working closely with the voluntary sector. Again, I think it gives us some indication of some of the ways in which we can engage with our communities in a bit more of a creative way. One of the things that I would say is that when we talk about patient involvement, and one of the good things about this report, Neil, is, and you and I have had these conversations many times over the years, this is about people, and I get a sense that we're moving away from talking about patient involvement to talking about, and not just talking about how we close that feedback loop in the way that you described, Aaron, as well, which I think is absolutely essential. It's the you said we did sort of perspective, but it's about much more than that. It's about engaging, again, we talked before with Sarah and Lizzie about engaging with people where they are and not talking about the services that we're already delivering, because actually some of this is about us getting better at serving our population right across all of those needs. And I see a bit of a shift within this report that I really welcome, because it's moved away from us thinking as a health service, this is about our patient engagement and involvement, into thinking about how do we reframe this a little bit and work with some of those communities that aren't our patients and aren't able to access some of our services.
Thank you, Tracy. Really insightful. Neil.
Yeah, so to answer Chris's question, some of it is about how we work on the ground. So I think certainly in a new ICB that's very much looking at some of our localities, it's about some of those teams working around population. So I think we'd hope to see more of that much more in the future. But one example where we have done quite a bit of work is across the communications teams across the system. So if you take a lot of the mental health messages that we worked on with your team that went out around the winter period, we'd already engaged with some of our kind of citizens advisors on actually some of their views on some of the things. So actually that really influenced some of the certainly promotional campaign messages. But there's, I think what you're saying much more is actually about how does that work on the ground. And I think there are examples of in our places where I think that is happening. And I think those are some of the main points.
No, thank you very much. I've got Andy, and then I'll bring Sam in.
Thanks, Chair. And I do actually just want to honour in front of the board how well Neil leads this team. He is a brilliant leader in this system, and the way that he has enabled his team and empowered them to really, really work, and the partnership that he's done with groups like Health Watch in this space has been really exemplary. So, Neil, thank you. It's great work. And I also want to highlight to the board, actually, that the Guardian newspaper have heard so many stories about what's going on in Lancashire and South Cumbria that they're running a whole series of articles over the next few weeks and months about some of the fabulous work that's going on in our communities. So it's really lovely to have a national spotlight actually on this way of working. It is so important that a paper like this comes to the board, because this isn't just a nice to do. This isn't the cherry on the top at the end. This is the foundational piece. This is the essential. Like, if we're not listening to our communities and really understanding what their needs are, we may as well go home. And we can get things so drastically wrong by not having the humility to just go and listen. Because often it's us who need to change. We think our community, they must change their behaviours. They need to change the way they're accessing healthcare. No, we need to change. And actually, we found that again and again. So, for example, when we went into East Burnley and we listened to the South Asian community about why their attendance at the Diabetes National Prevention Programme was so poor, that's what we thought. Actually, the reality is we were only providing them in Clitheroe in the wrong language and in the wrong cultural context. So we've completely changed it. We've built a beautiful relationship with that community. We now offer the course in Urdu, in the mosque in East Burnley, in a culturally sensitive way, which has been co-designed with that community. And actually the feedback from them and the transformed relationship has been astounding. And we could tell you stories about how we've majorly changed the way we're doing cervical screening with sex workers in Blackpool, or we could tell you the way that we are transforming our partner-provider collaboration with the Mental Health Trust in Fleetwood and seeing a 59% reduction in young people accessing our emergency departments for severe mental illness and getting that care with a 0-week wait for CAMS in Fleetwood now. Or we could tell you the story of how in Morecambe, by proactively knocking on the doors of people and transforming the way that we think about communities who are high users of urgent care and actually understanding what really matters to them, that we've seen a huge reduction in those communities of people attending the ED and actually getting much more involved in their local community and having their conditions managed up front, better prevention. So there's just so many good news stories from here. I think that I want to say to the board, actually, and it's certainly something we used to have it in Morecambe Bay, and I want to see it written through our commissioning kind of strategy now, is that no strategy will come through the process without this having been the first step. We look at the data, then we listen to the community, and then together with that community, we pull that through the entire commissioning process to make sure that the services we're providing are actually what our communities need. And that's where we see the transformation happen. So it's great work.
Thank you. Thank you very much, Andy. Sam.
Yeah, thanks, Neil. It is a good paper, and it does show that the great work. I suppose the point I really want to make is, as we're hearing, there is loads of good stuff going on, this operating model will give, and it's not hanging everything on the operating model, but the operating model, the work we will do together over the next couple of months will be really, really important to capture the stuff we are doing well and build it in. And actually Neil and the exec team, we've all working together on the designs, but that engagement piece, and Chris, when we come and talk to you about some of this, getting those thoughts about how do we set this up so that we are getting that feedback loop, and it's going to be really important on a local population footprint basis. But I think it's really important that we don't see commissioning, and people, you say a word like commission, it means lots of different things to different people, and it isn't, you know, us as an ICB holding the budget, buying the service off the providers, and that's it, and it's a contract. It's not that. This is about us being really collaborative. This is about us all being around the table, and I think if we get the design of this right, in the right way, we can build on what we've got, but we've got to, again, it's another example of where we've got to listen. So we want the opportunity for everybody around the table to input into this.
Thank you. Thank you very much, Neil. Thanks for the paper. I think there's a commitment to bring something like this to the board each time, because I think that's really important. I agree with you, Andy, about every single strategy. I've already said this. Every strategy has got to be built upon the insights that we learn. And I think also, given what you've talked about, Sam, we will be in a position to bring something more substantive around the operating model at the next board, won't we? And I think it would be good to be able to start to see some of this in action as to how it will affect the way that we, because it links back to the patient story. It's all part of the same picture. Great. Okay, so we're now going to move on to, I think it's the committee report, is that right? Yes, People and Culture Committee report. Jane.
Thank you. This was the first meeting of the new People and Culture Committee under the new governance arrangements. And the context for this, of course, is it came shortly on the back of the announcement for the ICB to reduce its running costs by 50% across nationally. So we spent time considering the impact of that on staff and how best to manage that, and so on, and that will be reflected through in the minutes. We noted the huge amount of work that's been done on the ICB cultures, values and behaviours framework, and absolutely agreed that even through such a difficult period as we're going to go through next for colleagues, that will be even more important work to make sure that we stick to kind of our values through that process. The committee is a system-wide committee, and we had a fantastic presentation from Spring North about their Volunteering for Health programme, which is a 3-year programme coordinating and developing infrastructure for volunteers in health-related across Lancashire and South Cumbria, building capacity and capability. And this is a fantastic project that will hopefully encourage more people to come into volunteering and also to progress across the system in different ways. And so we were very keen to monitor that going forward. One of the areas we discussed was around not just the impact on staff of workforce reduction, but the impact on students, and in particular for placements for nursing. And there's a real risk there that we will not be able to provide the same level of placement activity as previously. So we, as a committee, we're going to keep that under review via our strategic education group and ask for reports on that. We received a number of plans related to, so we approved the operational workforce plan, which is something we're going to keep track of, which is about tracking workforce numbers across the system. And we also reviewed and approved the business plan and the annual people plan for the committee to inform its work. We looked at outcomes from the staff survey, and colleagues will be aware because these have been presented to board previously. There is certainly action still needed on addressing some of the issues out of the staff survey, and our committee will be the one to kind of track that progress. We also looked at mandatory training. We had a referral, particularly of our audit committee, to improve the levels of mandatory training. We have a new policy now that's been approved by Remuneration Committee, We've also had a memorandum of understanding agreed across different organisations in the NHS across Lancashire and South Cumbria, which means essentially that people don't have to repeat mandatory training as they move from one place to another. We spent quite a bit of time talking about well-being and how we're going to support our staff through this next period of work. And finally, historically, particularly, there have been differences in triangulation between figures presented to finance committees and workforce figures and FTEs presented to people committee around the workforce plans. And we've got an ongoing action to make sure that we align that so that all plans are saying the same thing in terms of workforce and finance reductions. Happy to take any questions on that, Chair.
Thank you. Thank you very much, Jane. Sarah, and I've got Jim.
Thank you, Chair. It was just a comment really on the risk around, it talks in here about nurses, but I suppose it's for many of our professions that are about to qualify in the next year. We have definitely got a challenge because of the financial challenge across the system and the need to reduce headcount. There aren't necessarily job opportunities within Lancashire, within our large NHS trusts for cohorts of students coming out. And when we're talking about value for money, you know, to invest in training people for 3 years and to then not have employment opportunities for them in the sector isn't acceptable for any of us around the table. However, so it is a risk, and I'm really pleased that the committee are continuing to monitor that risk. However, I just wanted to feedback that on the back of that, we particularly knew we had a problem with a cohort coming out of one of our local universities. I did connect the primary care training hub with regional colleagues, and we are now exploring some opportunities there, and a similar social care sector, the voluntary sector, there will be some opportunities. So I think in a way this reflects the broader discussion we've had today, that we need to, when people are going for training, undergraduate training in any of the health professions, we need to be making sure we're opening up opportunities for placements right across the sector and start to educate students that actually going and working in a big hospital isn't necessarily the only career option at the end of that training. And I think there is still work. So I think as we do all the work we've talked about, getting alongside our communities, but also the 10-year plan and the moving care out, we need to simultaneously do work with the workforce, including the undergraduate workforce, that there are broader opportunities.
No, I'm pleased you commented on that, Sarah. Jim.
Thanks. It's really helpful to see the comprehensive work programme that's going on here. There's 2 items which I think we should be talking about at the board in a bit more detail, though. It's more than just board to note. One is the staff survey and what's going on that, because that's so important, particularly important at this point in time. The other one is the people plan, because we've never actually seen what's to be delivered through the people plan, and I think it would be really helpful for us to know in a bit more detail what's in the people plan, particularly for 25-26, if it's possible.
Thank you. I'm going to ask Debbie to come in on that. I mean, I think the people plan we could probably bring to the next board, couldn't we?
Yes,
Yeah.
yes, I'll be happy to do so. We developed a comprehensive plan on the back of, the strategy that was approved by the board in July, but also making it more relevant to our current climate. So we've got a comprehensive plan. It's sort of, we developed that before we had the announcement, so we've kind of had to shift gear and prioritise certain things for this current time, but we still got that plan. So happy to bring it to the board. And I suppose the other thing that might be useful for the board to see is the work we've done around the cultures and the values and the behaviours, because it was approved by the my understanding was approved by our committee, our subcommittee, but perhaps it needs to come to the board as well.
I think it does. I mean, we're going to weave it through our development session in June, but I was thinking it would come to the board in July. What about the action plan around the staff survey?
Yes, I mean that's a piece of work we've done across system as well, so we can bring that actually for across system as well as our own internal work that we've done for the ICB only. But the work around the staff survey is a system piece of work we've done.
Okay, so you're not looking convinced, Jim?
It's not that I'm not convinced, it's just that we have a very specific, our staff survey results were pretty appalling, frankly, and we need to see that position improve, and given what's going on at the moment, it's going to be quite difficult to improve that position, I think. But I think we probably need specific things for the ICB. System-wide is great, but there's also things for the ICB specifically.
So we as an ICB, we opted out of the staff survey last year, and the reason why we did that, which we agreed as a board, was because we wanted to focus on the reset. We wanted to focus on our journey around culture and the values. So we opted out, but what we did do during that time is run pulse surveys. So we've run a series of pulse surveys which the committee has been reviewing, and we have an action plan around that which we've continued to review as an executive team and board. But again, we can bring that to the board. But you're right, Jim. The most recent pulse survey, which we had the feedback in over the last couple of weeks, I mean, the response rates have been really low, and that's because of where we are as an organisation. And the feedback is not great, and again because of where we are as an organisation. But everything we've done in terms of our change plan addresses that.
Thanks. Sam?
So I don't think there's a problem with the information. We need to bring it back here, don't we? I think it's right and it's proper that we bring that back here, and it's open and it's transparent and we all can see it. And actually it's a good benchmark then to see how do we drive the right change forward and see what we need to do to put things in place. So I think we'll plan to do that, if that's okay, Chair.
I think we'll have a substantive session on people next time around. So we'll bring the values, which I think is really important. We'll bring the most recent Pulse survey, but there is an enormous amount of work going on as well, and I think it's important that we balance the enormous amount of work with the snapshots, because it's, in a sense, people are not going to be very happy at the moment. So, but I think we will have a substantive session on people at the next session. Thank you. Thanks for the question, Jim. Any other questions for Jane? No? Great. Thank you very much. Switch my life. So now we have the ICB final plan and budget. Stephen.
Yeah, thank you, Chair. So the report sets out the financial plan for 25-26 that was submitted to NHS England on the 30th of April. Just talking you through in headlines, Table 1 sets out the ICB indicative allocation of 5.4 billion. Table 4 actually sets out in high level where we're deploying the 5.4 billion. Just tables 2 and 3 are the national planning assumptions, so how we build up the plan. The ICB has a statutory duty to live within the resources, and we have submitted a balanced plan, so that's good news. Within the paper, it does set out that to deliver a balanced plan, we've got 142.7 million efficiency programme. That's broadly 3% of our allocation. In the paper, at the point it was written, we had 58.7 million of unidentified efficiencies. In the last couple of weeks, and work is continuing as we speak, we've managed to identify sufficient opportunities to deliver the target. But like any efficiency programme, there'll be risk in there. Some things will fall off, so we'll continue to work. We need to identify more than 142.7 million. And at each board meeting, we'll bring progress back on the delivery. I suppose just to summarise then, the ask of the board is to approve the plan, and also just for the support, to support the process of now issuing budgets through to budget holders. That's all I was going to say, Chair.
Yeah. Thank you. I think for consistency with the recovery and support position that we find ourselves in, it's important to note that the system does have the break-even position reflects deficit support funding of still 164 million. But that we have been told in no uncertain terms that is it. So the delivery of this plan is fundamental. But it does feel the plans feel far more robust than I think they did last year, and they have been all EQI aid. Questions? Thoughts? Oh, Aaron, sorry, thank you.
Yeah, thank you, Chair. I think the work that's gone into progressing the plan over the last month or two is substantial, both for the ICB and providers. So I think we've managed to put ourselves in a much stronger position at this time of this year than we did last year. But there are significant risks, both within ICB plans and provider plans. So one of the things that we will need to consider is a lot of these plans are not mutually exclusive. There is reliance on each other as partners in the system for these things to be delivered really well without unintended consequences. So I know we're talking about a review after the first quarter, Chair, just to talk about respective risks and starting to look about joint mitigations, so we don't take decisions in the year that kind of put pressure on each other. So we just want to make sure that we do that right through the course of the year.
Yeah, absolutely. Very important. Okay. I mean, it is a good plan, and I'd just like to pay tribute to the executive team because it has not come without an enormous amount of blood, sweat and tears. And we're going to continue to have to monitor it very, very carefully. Okay, now thank you. We are going to have a break. Yes, I tend to go into the zone, so I forget. So we're now going to have a break, 10 minutes break. It is, so should we say back at 2:30? Makes a nice resonance. Okay. Just before we reconvene, I did just want to say that we've had some very sad news about the death of one of our GPs, Dr. Zach Wakar-Udin. And I just, on the behalf of the board, wanted to pass our heartfelt thoughts on to his family. We heard that was news that we heard today. Okay, so our next item is the transformation roadmap, and I would like to ask Andy Knox, our acting medical director, to take us through this.
Thank you, Chair. I had my own condolences to Dr. Wakar-Udin's family and colleagues as well. Thank you. So, Board, I'm going to take the paper as read. This is a paper where we're beginning to try and set out our route map to transformation, our road to recovery. And the purpose of this item really is to offer assurance to the board about the direction of travel, some of our plans despite the difficult situation we find ourselves in, and to really welcome some debate and discussion and to gain the wisdom of the board to sharpen and strengthen this approach. So really I want to lay out three key things about the paper and then welcome discussion, if that's okay, Chair. So the first thing is the why. I love what Simon Sinek says, that we've really got to understand why we're doing what we're doing, because it drives the real sense of purpose and vision. And the vision of the ICB, and I keep telling the exec this, and I come back to it again and again, is the vision of the ICB is to have high-quality, community-centred services, health and care services by 2035. That is a massive shift from where we are now, and the potential is really huge, actually, if we get this right. And it aligns with the three big shifts that the Secretary of State is talking about. So he is constantly talking about, and all the health ministers are talking about, the vital need to shift from acute care to community care, from analogue to digital, and from treatment to prevention. And the reason for that is based on the diagnostic report that the Professor Lord Aradazi wrote about the state of the NHS at the moment. And to remind us, the vision of the NHS, still after 75 years actually, is to ensure the best care for everyone free at the point of service. What a remarkable vision. We actually understand the why of the NHS, and to remind ourselves about how we need to transform to make sure that that's a sustainable vision for the future is really important. And so I want to talk a little bit about the how and the what. The how really has two parts to it. The first is what we call the quadruple aim. And this is work that's been done by the Institute for Health Improvement out of Harvard, and also is already part of the very core strategy at LSCFT, and that we're beginning to see across all of our providers, and that we align with. And it's really got, obviously, four parts to it in the quadruple aim. The first is we want to make sure that we're improving the health of the population whilst we tackle health inequity. The second is that we want to ensure that we've got really high quality care in terms of access, experience, and outcomes. The third part of that is that we want to ensure that we have happy, healthy staff who have a real sense of joy and pride in their work. And the fourth part is that we want to ensure that we actually use our resources really well and are financially sustainable for the future. And what we're seeing at the moment is a new blueprint, the second part of this, and the how, is that there's going to be a big shift in how we are operating as an organisation to ensure that we're able to commission the right kind of services to have a properly neighbourhood-led approach to health and care. And so we know from what is now coming out of the Department of Health and Social Care that we need to be using our insights around population health and our digital insights and business intelligence capacity to really drive some of the changes. We then need to really understand the needs of our population, and that's why the work that, and the paper that Neil presented is so essential to how we go forward as an organisation. We then need to make sure that we strategically commission actually what our population wants and need, and that we're then able to evidence whether or not the outcomes are working and continually improve. Now, so that's the how. We've got a quadruple aim, and we've got a new commissioning framework that allows us to adapt and become more agile as an organisation. So what are we going to do? And that's what our roadmap begins to set out. So in 25-26, although it feels like quite brutal work some of the time, it's actually vital that we do get our finances in order. We cannot do the quadruple aim if we've got a balloon that is way outside of our envelope. We just can't. And it's everyone's responsibility. It's clinicians' responsibility in our health and care service to make sure that we are not overspending the resource allocation that we have. And so we know that we've got to get our ship correctly set around that. Then through 26, 27 and right through to 2030 and then onwards, we need to recover, but we then begin to need to transform. And what the roadmap sets out is, having done a huge amount of engagement across our system, the listening to our communities, the working with multiple partners across the organisation in an integrated way, is we know that we've got some areas which actually, if we get it right, will have huge transformative capacity and enable us to work in a much more upfront neighbourhood-led way. And those are particularly, I'm going to name the big four, although there are other programmes that sit behind this. End of life and frailty. We know, for example, that of the 16,000 people that died in Lancashire and South Cumbria over the last 3 months, between them, they took up 250,000 hospital bed days. On average, that's 11 to 12 days each in hospital. If you talk to most families about how they would like their loved ones to be at the end of their life, it's not that. And so it's incumbent on us to actually transform the way we talk together about death and dying and how we enable end-of-life care to be as brilliant and beautiful as it possibly can be. So we've got a big program of work around there. And actually, the truth is that unless we do that work, our system simply isn't financially sustainable either. So it's really important. The second is around managing long-term conditions in primary care more effectively. At the moment, there's huge variance and in terms of quality and outcomes across primary care, but there's also been a need to be able to proactively work with our communities, find people earlier, and help make sure that they're treated in a way that prevents them becoming ill in the long term. And we've seen a bit of a shift in thinking around this. So let me just, for example, highlight to you the issue of hypertension. Outside of smoking, which we've also got a huge strategy around, hypertension is the biggest single risk factor for cardiovascular disease in terms of strokes, heart attacks, and actually now dementia. And yet we've had lots of people who have uncontrolled hypertension. And the chief medical officer has said, we've got to intervene earlier. We've got to get in there with treatment and help people change their lifestyles. But let's not wait around for people to change their lifestyles. Let's protect them from becoming much more unwell and intervene earlier. So we've got a big program of work around long-term conditions, including cardiovascular disease, diabetes, respiratory, chronic kidney disease, a whole load of different bits and pieces in every single one of our primary care teams right across Lancashire and South Cumbria. And then we need to make sure that we get intermediate care right, the step-up, step-down facilities, and we've got some great examples of where we're beginning to learn and do things differently, for example, work that we've seen in Barrow in recent months. And then we need to think about service reconfiguration. Where are things just not working for our population? And how do we learn to do things differently in a much more joined-up, integrated way? All of this is going to allow us to put a much bigger focus and emphasis on our neighbourhoods and our places and work in far better integrated way with our teams to ensure that we are providing the very best care for the communities that we love and serve across Lancashire and South Cumbria. Chair, back to you.
Thank you, Andy. There are various slides in the pack which sort of set this out, but I am hoping that we can have quite a debate about this because it is absolutely fundamental, as Andy has so eloquently set out, to our future direction. So, thoughts? I've got Sarah, Jim, Aaron. Okay, let me write names down. So, Sarah.
Yeah, thank you, Chair, and I really welcome this, and obviously we've been involved in this together as an exec team, and I think it's a really good example of how we're demonstrating the vision in a much clearer way. So this is a new thought, actually, because I do think it brings out all the key things. However, listening to the population experience today and then the subsequent discussion, it's just a thought. I wonder whether we could actually strengthen it by not changing the air. Well, it's two ways, really. One, this is still quite health focused, you know, and maybe that's what we want. I think one of the debates for us is, do we want this to be our roadmap of the transformation of health services, or actually would it be better, and this would be my personal view, if we build into here some of the things that would also be system, because it would be with partners. So, for example, on the children and young people, and that's got all the right things, all the things that the team have inputted around health. But actually, there's a number of things that are also, I'm thinking of the integrated care strategy and better start in life. So actually, we could probably strengthen it even more if we include that as part of the vision. And I think each of them you could go through, and particularly building on the population experience we've seen today. I'm just wondering if we could strengthen it by making it more about the wider health and care agenda, and not just about patients and health, which I think is the point Tracy made earlier. So that would be a comment from me. But really, it's really great to see it put out in this way.
Thank you. Thanks very much, Sarah. Jim.
Thanks. It's a really good piece of work. I think when I read this in isolation, I was concerned about the fact that there's, towards the end, that there are, I think it's 9 programmes of work, and when you look at all the things that have got to be done, there's 47 actions to take forward, which I'm thinking, how are we going to do that given the circumstances? But the way today's conversation has evolved, it feels like it's not just us in isolation, this is a joint effort across the system. And somehow, I think converting some of this roadmap into, without going too deep, into more detail, so we can see how this really starts to come to life. It feels like it's been coming to life today, and I mentioned in a conversation we had yesterday that it was very helpful to see the Provider Collaborative Board, what it's taking forward around a whole series of acute services rationalisation. It almost feels like we've moved forward almost in the last few weeks. There's been big steps forward. This is the next big step forward, but it feels like we need to just perhaps work this out a little bit further so we can be convinced, because there is a degree of scepticism amongst all of us, I guess, because this is not the first time we've been here. It's almost like the third time we've been here. Each year we seem to have got to this point and then we've not progressed it. There seems to be a much greater head of steam behind it now than there's ever been. So I'm far more confident, but it would still be helpful to just, I think, flesh this out a little bit more.
Might be helpful if you talk about some of the conversations that we had, partly of the preparation in terms of working with the PCB, because it's sort of, there's a need to sort of, we need an action plan. Who's going to do what when, isn't it? But actually, that needs to be agreed across the system, and there's work underway to do that, isn't there?
Yeah, so happy to do that, and I don't think it's just the PCB. It's the wider partners as well. I think just to say, this roadmap work started, say 6 months ago. I'm going to say maybe 5 or 6 months ago, and I think it has been building up. And the idea when we started this was that this was going to drive our commissioning intentions, which is probably why it is a bit more health focused, because it was looking at that through at the time. I have to give absolute credit to Andrew Bennett and to Terry Worley, who's also been driving this, but it's been through wide engagement, which included the Provider Collaborative, so they've been round the table on this. However, I do think there are other groups, look at Tracy, that perhaps could benefit from being tied in. Part of the discussion that we've been having, I suppose, has been, how do we get the infrastructure right across the system to do this really well? Because at the moment, it's not quite right. And I haven't got the answers yet, but it's part of what we've agreed we're going to do in the conversations with chairs, chief execs, but also with some of our partners, or all of our partners across the system, to say, how do we get this right now to actually execute and deliver what we want to do? So you're right, Jim, we've been here before, and we get to delivery and it stops. How do we make sure we unlock that through the right governance, the right delivery, and the right people? And I think it's got to include more than health, to be honest. But I think that's because it started with a group of commissioners and senior leaders and PCB in a room thinking, how do we set our commissioning intentions through the ICB? So I think it will evolve, but we haven't got all the answers yet. But it's definitely the right piece of work to do next.
Thank you, Sam. Aaron.
Thank you, Chair. Yeah, I think it's an interesting reflection about what we mean by provider collaborative. I think the Provider Collaborative Board, as it was established 2 or 3 years ago, essentially has a joint committee at its heart, which is the 5 trusts. I think we're much more ready to talk about provider alliance now, and how do we sit more connected across the system as a group of providers with the ICB as a system leadership group. but I know we're going to talk about that in the future. I think this piece of work, when you read it in isolation, leads to questions around delivery plan and the what, by, when, which is right and proper, and we should do that. I think if you look at it in the context of the commission intentions kind of documentation and then the blueprint work, you can start to see an operating model shift with a roadmap and then a delivery vehicle that really starts to make sense for the system. So I'm really excited by the opportunity. I get it comes with disruption, it's really difficult to do, but this is starting to build, I think, a cohort of a story that people are really going to engage with. I've got 2 quick points to make if I can. So I really do believe in the kind of the reflection of what gets measured gets done. So it's interesting with the roadmap. It's not until you get to long-term conditions, end-of-life frailty, where you start to see some figures in 28, 29. Everything else is around intention. So I think one of the ways to bring people in is the so what element of this. It doesn't have to be the delivery plan, but if we're going to focus on cancer, to what end? If we're going to really focus on end-of-life and frailty, what's our ambition? So I just think there's some things, particularly for our communities, patients, service users, that they could really buy into what would be different when we focus on this roadmap. And then the second point is probably a little more contentious, Chair, which is I think we need to have a conversation in the blueprint kind of next steps with NHS England about the performance framework in the operating model, because we're still held to account largely on monthly and quarterly performance, whether it's performance targets or finance. Some of this roadmap and the commissioning intentions is going to need longer and medium term delivery oversight, which can be, I think, it's come second order when you're under pressure, particularly in the framework we're in now. So I think there's a conversation to be had with the system about how are you holding us to account on the medium to long term strategic delivery, because we're going to have to deploy resource and time on this.
Thank you. That's quite an important point. That's something we could note actually as part of the outcome of yesterday, isn't it?
It is. And I think as well as that, we know that the national team and the policy committee is to start looking at multi-year planning, and I think that's an important factor in there as well. So we need to be looking at this over a longer period than 1 year. So I think we should feed that in. Thank you.
Thanks, Aaron. Tracy.
Thank you, Chair. I want to pick up on the fact this is very health focused, but maybe frame it slightly differently to just really bring my point to the table. I really welcome this. I think it's really easy and clear to see, but I think it's a product of a system under grip and control that becomes quite internally focused and starts looking at health and our roadmap in terms of limited resources. I think we've got some really difficult conversations and difficult decisions ahead of us as a system. And I'll give an example just to give you an idea of what I mean. When we talk about long-term conditions, and Andy, you mentioned respiratory, if we don't look at that in terms of what's happening for our population, so if we want to prevent somebody becoming ill through a respiratory condition, a lot of this is about their living conditions. Is somebody living in a cold home? Now, are we, as a system, going to try and treat people and send them back to cold homes? Whose responsibility is it to make sure that somebody doesn't end up back in a cold home? Now, we've been doing some of this work, but there's still a big question mark over what resource is used to ensure that somebody's needs are met outside of that health and care kind of what we consider to be our responsibility. So whilst I think this is a really great roadmap, there's a layer to it that at the moment I think coming out to us, and Andy, I know you and I have talked about this recently, about how we involve the VCFSE and the Alliance in some of this work and some of those really difficult decisions, or some of those opportunities, because I think there are other budgets, other ways of accessing funds that we're not really making the most of at the moment. And we're treating this as very much we're treating long-term conditions, we're treating people with their health conditions, when actually there's so much more going on. And I'm not telling anybody anything they don't know, but I suppose framing it like that might give you an idea of what I would expect to see in a roadmap going forward.
Thank you. Very helpful, Tracy. Craig.
Yes, thank you, Chair. And I think this is a real step change for us, and I think when we're talking about strategic commissioning of the future, I think this is absolutely the right direction of travel, and Andy does bring that passion and energy, but also that positive disruption, because I think this is not about doing what we've always done. I think as well, this is really truly starting from an asset-based approach rather than a deficit model, and I think we can do more to probably bring that to life in some of the narrative, because when Andy starts to talk about it, you can hear that population experience coming through, and I think that's something that we should really maximise on. As we all know, transformation is a part of our strategic commissioning cycle and process, so it's a real critical ingredient for success. And I suppose what I want to say is now this is clearly dovetailing with our commissioning intentions. This is not a separate programme, so when you look at the programmes that Andy's articulated, they're absolutely anchored into what we want to see as a part of the transformation. And I think for this board it's about having that strategic conversation about the priorities and where we want to see our energy invested to make that difference, so the added value. And I know, Chair, you often bring back to the impact. What is the impact here? How are we seeing our outcomes improve for the population? I think this roadmap is really on the journey to do that. I think there's some finessing to do, and I think Tracy's point on the frame is really important, but I'm hoping people can see now what you'll get as Andy and I and others start to work through the year is the commission intentions and the roadmap intrinsically linked so much. We're just talking about our plan rather than two separate documents. So I'm really pleased to see how much this has progressed even in the short time, because there's been other areas that are at this a couple of years before they start to see real progress. I think there's been, you know, to the team, some lots of heavy lifting here, and I think we're starting to see the fruits of our labour.
Thanks. Do you want to come back, Andy?
Do you want me to come back at the end or now?
I was going to suggest you could, yeah, I was
I'm happy either way.
we've got another two comments. Should we
Take the comments first?
Yeah, let's do that.
Thanks.
Steve.
Yeah, thank you, Chair. So notwithstanding what I've heard colleagues say, what I was going to say and still will say, as a newcomer to this organisation, trying to understand it and its aspirations, this was the clearest exposition that I've seen or heard as to what we're about and where we're going. And it's very exciting and very enthusing, so it's good to be. When we had our catch-up yesterday, I hadn't read it yet, otherwise I might have mentioned this, but I do so now. It's very helpful. It also occurs to me that, as we've heard from Sam and others, a number of colleagues won't be coming on this journey, and that's very difficult, but they will be able to be proud of what they leave behind if this is what is in place in 2030. So that's great. Thank you.
Thanks, Steve. And I've got Saxi.
Thank you. I'm not going to repeat what everybody else has said, and it's really needed, this roadmap. We were all working together, and it's good to see this coming through. Just want to highlight a couple of points. Our health outcomes are going in the wrong direction in Lancashire and South Cumbria, and the inequalities are widening. So the least we could do is to be the best that we can be as individuals, organisations and partners. And by that I mean to improve health, it takes more than improving healthcare. And we need to keep coming back to it as how is this roadmap, how is this road going to be another lane in the wider roads or paths we're going to have to build. And there is so much change in the wider society, public sector, market economy. All of this is going to buffet against this. The framing of this, I mean, the interest in the spirit of provoking some debate, the framing of this, I feel, could start with our future, which is children and young people. It feels like children and young people have been added on to the last lane of the roadmap. So we need to start with the future and begin with getting the best start in life for our families and children. And I know there's work happening in the background, but we need to be absolutely crystal clear about outcomes. just as an example, if smoking is still the biggest killer or if hypertension is the biggest risk factor, by 2030, exactly how many less smokers are we going to have and where are they now and what's our, going back to action plans and month by month. We can do it. We've got the expertise, we've got skills, not just within the ICB, across the partners. That needs to be leveraged. And a couple of other things, again, in the spirit of provoking debate. NHS is the main organisation people look to for health. They don't look to housing, they don't look to DWP, they don't look to education as the sector for improving health. Whereas the paradox, on the contrary, is those sectors do more to improve our health than the NHS. And those sectors are building Lancashire's assets of the future, whether they are building new schools, building new workplaces and all of this. And we just need to have that sort of longer term, provoke even more longer term than the 10-year plan that's going to come. Because if you look at our new houses, our local plans, they are 30-year plans. So I suggest the road doesn't end in 28, 29, and we need to be thinking beyond that. And the final couple of things is just the language and our understanding. I'm not entirely certain. When we mean by system, do we mean NHS system? Do we mean community system? Do we mean public sector system? I think my appreciation is that if you're in the NHS or in any particular public sector, it's very hard to think and go to the margins of that sector only to appreciate that we are in a bigger system. I'd keep highlighting that point. And then the final one is pretty much all the public sector, including the NHS, is actually designed to be waiting for people to knock on our doors when there is a need. And then once they do knock on our doors, we are very well known to suck them through our doors. And the back door is not really flowing very well either, and keep them. And there's a ballooning cost demography and all of this. We've got to somehow go beyond our front doors into the community, into the garden, or whatever you want to call it, actually to engage. And there's only a very fraction of our resources and activity actually is deployed in that way. But we know that next year, the year after that, our needs are only going to get bigger and bigger. So there's a huge economic case we need to start building and advocating for making this roadmap a success. Thank you.
Thank you. Thank you very much, Sakthi. I'm going to hand back to Andy to respond to some of that.
Great, and thank you all for really, really helpful comments. It will help sharpen and strengthen this work. Just a few comments, if I may, Chair. The first is to say that we absolutely recognise with real humility that only 20% of people's health outcomes have anything to do with the health service. Like, we know that, right? But I also have the words of Colin Cox, the Director of Public Health for Cumberland, ringing in my ears when I said to him, what should we be doing? And he said, would you please get the NHS house in order? So there is that dynamic, isn't there, where we're part of an integrated care partnership, where together and with our health and wellbeing boards, we're looking at the wider determinants of health, and we will absolutely play our part. But we also have to get our own house in order. There's loads of variance in quality and outcomes for people, particularly in our most disadvantaged communities, and we blame it on the wider social determinants of health. But actually there's loads we can do and are doing around proactively reaching out and working with those communities radically differently, as we've already heard from the story this afternoon and from Neil's paper. So I just want to get that balance right in the debate, that there is still stuff that we as the NHS need to do, and our job as the board is to make sure that we in the NHS are playing our part in this jigsaw. So it's a humble part of the jigsaw, but it's an important part. We mustn't let that go. The second thing is, in the kind of reworking and the resetting of the ICB blueprint, which Sam touched on earlier, we are going to look at much more strengthened, integrated neighbourhood teams, which automatically pull in partners from across the CVFSE, local government, social care, primary care, mental health, our acute sector. And so we actually see that on the ground working. This is actually how we work. This is how we're doing it. This is our modus operandi. And actually, we are doing it in partnership because we have to work simultaneously on the wider social determinants of health that people are experiencing in their communities and neighbourhoods, and the stuff that we can do in the healthcare service to intervene and help and do that. And if you look, for example, at some of the focused outreach work that we're doing in Rylands Estate in Lancaster, that isn't about pulling people into Lancaster Medical Practice or Queen Square. It is actually about having put a complete new service, having listened to that community and totally transformed the way that we're providing services in that community, with that community, in conjunction with Lancaster City Council. We've totally transformed our model of care, having listened to that community and looked at what the data's telling us, to the extent that 50% of that people who live on that estate have actually had an enhanced health check in the last 12 months, with huge picking up of all kinds of health problems that we were completely unaware of before, and a 10 to 12% reduction in use of emergency care and non-elective beds. So by working in this way, we really can make a difference. I absolutely take the point that then that means that we need to look at where resource allocation needs to shift. We can't keep spending our money in the way and the places that we're doing it and expect to make a difference for the people who need our help the most and who are actually driving the most cost in the system. So it's about thinking on that population health scale and how we do that well, and then working in real partnership in our place teams to make sure that actually the approach that we're taking in Pennine, East Lancashire and Blackburn has got to be different around the housing needs there and the smoking needs there and the obesity rates there compared to what we might be seeing in South Cumbria, right? So we can't just say, well, one size across the system and it's all the same everywhere. It isn't, but that's where place-based partnerships are going to be so vital as we move forward to make sure we really can do this at a neighbourhood level in a really intelligent way. And just to demonstrate how much we've shifted and changed, if this board were to read the 5 strategies in our trusts around how the trusts want to play their part in tackling health inequity, you'd be staggered by how the story has shifted in our trusts and actually in our primary care providers as well. And I just want to give 2 examples from Sarah Morrison, as she is now, having just recently got married, Chief Nurse at Lancashire Teaching Hospital. So she's also come through our Population Health Leadership Programme. And I have to say how happy I am to have heard that mentioned a few times this afternoon, because I think it's a piece of learning where relationships have been built and people are hugely shifting the way that we work together as a system and as individuals as well. And so Sarah noticed 2 significant pieces of health inequity that were happening for people walking through the doors of Lancashire Teaching Hospital. The first was that she noticed that no one in the deaf community in Lancashire and South Cumbria has died in a hospice in this patch in the last decade. And she was really curious about it. Why on earth not? We have quite a large deaf community across Lancashire and South Cumbria. It's something I feel really passionate about because my daughter has significant hearing loss. And when she went and spent time with people in the deaf village, what she discovered was there is no word in British Sign Language for palliative care or hospice. So she's worked with the British Sign Language community to invent 2 new words. And recently, we've had someone from the deaf community die in one of our hospices. You see, she had to work with the community voluntary faith sector. She had to work with data and digital. She had to go and listen differently to that community. And then she's redesigned care to make sure that we do things differently. And the same when she noticed in St Matthew's ward that we heard about earlier, that there were significant early deaths actually from bowel cancer, we found out, but people were presenting so late that they weren't even getting properly coded. She said, we need to work radically differently with the predominantly Muslim community in this community. And she went to the imams and tried to build a different relationship. And they said to her quite honestly, well, when you show that you care about us as a community, we'll begin to work with you differently. She said, how can I show you that I care? They said, well, you've got loads of Muslim doctors and nurses in your trust and AHPs, but they don't have a place to pray. Create a prayer room in the hospital. Show us that you care about our community, and we will begin to work with you to bring change. So she did that, and the imams then opened their arms and opened the doors to a completely different conversation, where we now have far better bowel screening rates, a completely different conversation and relationship with that community. And guess what? We're beginning to see people present much earlier with far better outcomes, and we're going to change the story together. So I just want to say this roadmap is already in action. Our partnerships with community voluntary faith sector and public health and other partners are already really strong. This is how we're beginning to work. We're already on the road. And actually the opportunities for us to do this bigger and better with more humility and more relationship is utterly transformational in the months and years ahead. And so really, really grateful for the comments. We will take them back. We will strengthen this approach. But I do want to commend it as the right way for us to go forward.
Thank you, Andy, and thank you for the passion with which you present it. Sam.
Yeah, thank you, and thank you for Andy for that, and for also agreeing and committing to take those comments back, because what I've just witnessed in that whole session really is actually some very good open challenge, and that's what we've got to have. You know, we've had the so what from Aaron, and we've had this sort of real challenge around health and traces as well, you know, about cold homes and thinking about budgets and how we use them. And, you know, we've had a number of people around the table that have just come back and said, well, what about this and what about this? And I know I've spoken to Chris outside of here about mental health and the input into it. I think what was really important there is you just committed to bring back those thoughts, and that's what we need to do more of. So it's great that we've got a board, I think, that will challenge each other, and that's where we'll get a better product at the end of this. So well done with that. Thank you.
Thanks very much indeed. Okay, we're now going to move on, and we are going for, yes, performance overview. So starting with the reporting from committees, escalation and assurance reports. So just to say that further to the paper we brought at the last board of the change in committee structure, this section does still contain the final AAA report and approved minutes of the Public Involvement and Engagement Advisory Committee, which Neil will present in the absence of Debbie, and also the approved minutes from the last Primary Care Commissioning Committee, which Deb will present in the absence of Debbie. So, first of all, Primary Care Commissioning Committee.
Thank you, Chair. And it's just to receive the approved minutes pertaining to the last meeting of the Primary Care Commissioning Committee held on the 13th of February. The AAA report from that meeting was received and discussed at the board meeting in March. And under the new committee arrangements, primary care contracting now sits within the Executive Committee portfolio, and reporting from the Executive Committee will be brought into the board, as does all of the other committees going forward.
Thank you. That's helpful. I'll move then to Quality and Outcomes Committee. Sheena.
Yeah, thank you. I just really wanted to just begin by talking about the future with the Quality and Outcomes Committee. So, and then I'll come back to the report you've got here, because that's in the old format of the committee. But I just was, as we've been talking all afternoon, reflecting on the way that we are changing as a board. And really the opportunity moving towards a Quality and Outcomes Committee is where we're going to bring the threads of a lot of what we've talked about today, and thinking about how do we really get that assurance that we're having the impact that we want to see in changing the outcomes for the people that we serve. So it's going to be a very exciting time as we start to think about how do we change the Quality and Outcome Committee to really provide that really important assurance about that, and to think about points that were made about how do we measure this, how do we bring together an integrated report that brings all these different strands together so we can see it in one place, not in the way that we've kind of sort of seen it in a disparate sort of different pots and silos of working. So I'm really looking forward to working with colleagues to how we shape that going forward, and naturally it will iterate as we learn, as we go along, as we start to do that translation and transaction of our transformation plan and our roadmap, and to bring it into reality. So you know, it is going to be, I think, a really important part of how do we get the so what and the impact about what we're doing and the changes that we want to see. So I just wanted to make that point, if I may, Chair. I think just to then go back to the report you see in front of you, it was in our old style, so I don't want to go through the detail of it because you can see it in front of you, but just to pick a couple of items out, if I may. And the first of those was around the quality impact assessment. So you'll see the report there that we noted that the process isn't yet fully embedded, and that is clearly a work in progress. However, at our recent committee, we've seen further good progress on this. And the other point I just wanted to mention on the alerts is about histopathology, where we are still ensuring that we want to look at the improvements going forward on that particular issue that we have in one of our providers. So then moving on to advising, I just wanted to pick one thing out from that, if I may, which is around our South Cumbria neurology services. and to advise that we've now have a provider identified, but as a committee we want to see how that is working out and whether that's actually having the outcomes that we want to see there. And then finally, I just wanted to just mention that we returned in our assurance part of our report to the alignment of community services for Blackburn with Darwin and East Lancashire, and we took a report at that meeting in March to look at a 6-month post-transfer update, which was looking about what was the outcome of bringing together those services in a different way, and the report to date was that those have embedded well. So that's all I wanted to pick up, and happy to take any questions. Thank you, Chair.
Thank you, Sheena. Are there any questions for Sheena? No. No, I would just reinforce what you said about the future direction of the Quality and Outcomes Committee. It's going to be absolutely fundamental for us as it went through any change, assessing the impact on the end users, so to speak, is absolutely fundamental. Thank you. Finance and Contracting Committee, Steve.
Thank you, Chair. I'll talk to the report I presented the 15th of April, which is the first committee that I chaired. I won't go through the report in detail. Suffice to say, the coverage of the committee related to elements for the close down of 25-26, as is normal at this time of year. We discussed the activities going forward with the terms of reference for the committee, in particular following the movement from being finance and performance to finance and contracting. But what this report does, particularly in the bottom of the Assure section, is I think highlight the future plan for the committee going forward, which is very much around monitoring where we are, looking at mitigations, particularly supporting the ICB and getting off the naughty stir, which is absolutely fundamental, because if we don't do that, we will not have the capacity to do the things we need to do. We had some really good conversations, so you'll also see in there we identified a range of deep dives we are doing. This one highlights all-age continuing care, which we actually did at the last committee meeting that I chaired earlier this week, and got some really good feedback in terms of the work that's ongoing, managing those cost reductions. But suffice to say, there's a pretty big stretch target in there. The reason I raise that is hitting those financial targets at the end of the year to demonstrate to NHS region that we are a sustainable organisation. The end product may well vary from what we have now. The reality is some things will happen, some things won't. What matters is we hit the end target. What also matters is we hit it with recurrent savings, not elements of non-recurrent savings. So these are the things that the committee is engaging in. So you can see in the very bottom on the sorts of things that we're focusing forward, and working with Stephen to start to produce the reports that will come to the next committee meeting that will enable the committee to discharge that. So very much focusing on delivering that year-end outcome. I'll happily take any questions.
Thanks very much, Steve. Any questions for Steve? No. Okay, that's excellent. Thank you very much. We then have, where's my agenda? Finance and contracting. Yes, PIAC. Last AAA report for PIAC.
Thanks, Chair. As you say, the committee has now been disestablished, which does mean we can stop using the acronym PIAC, which is actually quite helpful. A lot of what we talked about in the committee was recognising some of the work and the achievements of some of those members, particularly in how we've laid some of the foundations. And I think it's important. We talked earlier about the engagement report. We have established some foundations, but there's still a long way to go. So I know obviously there's some positive work in there, but there's still a lot of work we need to do to make sure we're listening to people in the best way possible. A number of the items in the paper actually talk to things that we've already talked about already. So particularly how we report into the board, how we work with some of our partners, and how it links to some of the commissioning framework. There's two areas of assurance that are probably worth mentioning, particularly how we discharge our duties around kind of formal service change and some of the formal service change processes, which is important. And Sheena's just mentioned some of that work around the Quality and Outcomes Committee, where some of that engagement involvement work has moved to as well, which I think is really positive.
Thank you. Thanks very much, Neil. And it's pleasing to see that a lot of the stuff that was in there is covered, because that means the board is covering that absolutely fundamental pillar of what we do. Excellent. Jim, North West Specialised Commissioning Committee.
Thanks. Yeah, there's two AAA reports, and one almost supersedes the first one, because there's an alert under the first one about the concerns around recruiting because of the potential delay in the TUPE transfer. The second one says that it has now been delayed further, and we're not quite sure where that's at the moment. So that's operationally a big problem for the specialised commissioning team. There was an approval in the reference in the March one about the premature retinopathy, and that's kind of about the one decision we've made so far in the committee, really, and that was helpful. Other than that, the committee it's working pretty effectively, I think, but we're not actually agreeing much at this point in time, so slightly frustrating when we go along to these meetings.
Thanks, Jim. Any questions for Jim? Can I just ask, Jim, would you know, I've been reading up about the fact that the staff for specialised commissioning are no longer, there's going to be a delay in the TUPE across. Does that have any impact on the operations as far as you're concerned from a committee perspective?
I think Craig probably knows better than me because he's working very closely with those guys. I don't think it does particularly. I think the bigger issue is they got a freeze on recruitment, so they've got a load of gaps in their team already. So the gaps in their team is having an impact upon what they're able to do.
Craig?
Thank you. So, as you know, we were planning to transfer the Specialist Commissioning staff from NHS England in the next couple of weeks, and that's been formally paused. I think a decision has been taken now formally by the National Executive. And what the narrative is now changing to is because it won't be able to be delegated from NHS England because it won't exist, it will now be transferred to ICBs. So I think this period is to look at exactly what's transferring. So we knew there was a significant number more of specialised services, also Section 7A, vaccinations and screening, and now health and justice. I think they're going to review that to see if there is anything further, because there should have been some more retained by NHS England, but I'm not sure there is the appetite. So I would imagine it will be the very specialist national provision that will stay centrally, and therefore it will be transferred to us, and that transfer will be different to a delegation agreement. So I will need to bring something formally back to the board. There are operational challenges with the specialised commissioning services because they are subject to obviously the recruitment freeze. And that does mean we're operating on a lower number of specialised commissioners within our patch, but we're working very closely with them on where we can support and do some integrated work across the ICB and SpecCom.
Thank you. Lots of moving parts. Okay. So now we move on to the Integrated Performance Report. Asim.
Thank you, Chair. So this is the report in the pack. Contains data until the end of March, so data until the end of the financial year in the main. And what I'm going to pick up on is the increasing demand and pressures we have seen over the last 12 months. And I think before we do that, I think it's important for us to pause and reflect on the extraordinary effort from all of our teams in our provider organisations, primary care, voluntary sector. Because what we've seen, even with the increasing demands and pressures, which we'll go through in a second, we have maintained our performance, and our performance on a number of our metrics compare favourably with Northwest and national averages. And as I said previously, I don't think we can just look at these numbers because there's people behind them, there's people's efforts behind them, and I think we need to avoid seeing things as just red and green. So as we look at emergency, urgent and emergency care, compared to 23-24, we saw 47,000 more attendances in 24-25. That's an increase of 5.4%. And even with that increase, we saw our improvements in our UEC, where we saw 76.89% of our attendances being met within the 4 hours, performing better than the Northwest and national averages. 12 out of 42 ICBs in the country. And we've seen a further improvement in our UEC performance again in April. But just to remind the board on where we were before the pandemic. So in January 2020, we were 81.5% in our performance with a target of 95%. So we are slowly getting back to that. But we are seeing 147,000 more attendances since the pandemic, which is a rise of 21%. So this underlines the achievement of our people working in these services. So we need to recognise that. And on a slight tangent, moving away from UEC, we have seen similar increases in our primary care. So primary care compared to last March saw 5% more increases. And compared to the overall, in 23-24, there were 9.9 million appointments in GP. And there's a massive number. This year we saw 10.2 million GP appointments. And the appointments were sort of the targets around the appointments were largely met with the context of us having a much less workforce in terms of weighted population compared to Northwest and national averages. And in some areas, it's significantly reduced workforce. And again, just we need to reflect on the work that our GP practices have done in this respect. I'm going to move to diagnostics because I was absent at the last meeting, but I recall there was a lot of conversation around diagnostics. I was pleased to say, and we've not been able to say this for many months, we have seen an improvement in performance in our diagnostics, and 3 of our providers now are actually above the national average. Lancashire Teaching Hospital remains quite challenged, so there is variation in that performance. There was some question last time around community diagnostic centres. As the board will be aware, this is a key national policy, and we have 8 community diagnostic centres across Lancashire and South Cumbria. And in 24-25, we conducted 200,000 tests, so which is a significant proportion, 12% of our diagnostic activity. And triangulating back to Neil Greaves's paper around insights and communities, Health Watch did a sort of review of our community diagnostic centres in Rosendale, and it received very positive feedback. It talked about the dignity in having a diagnostic centre closer to the community, travel sort of aspects as well. So very positive feedback being received through our Health Watch in terms of the community diagnostic centre. The last bit I'm going to talk about is mental health. So we're also seeing a lot of increases in our mental health, people with mental health conditions. And yes, absolutely, there's a target of having 0 inappropriate out-of-area placements. But compared to this time last year, we had 26 patients in appropriate out-of-area placements. This year, this time, we have 14 patients. There is progress. It does fluctuate, but there is progress around there. Chris, in the last meeting, sort of made a plea to have continued focus around learning disabilities health check. This has been dropped from the plan, the annual plan. But there's a commitment that we do see this being absolutely important, and it's in our trajectory, and we'll continue to report on that. And Lancashire and South Cumbria met their target of annual health checks for learning disability. And the reason this is important is massive inequalities in these areas. On average, women with learning disabilities die 23 years younger than women in general population, and for male, 20 years younger. So this has to be something that we have to focus on based on what we've talked about throughout the day. And ICB will continue work with the health facilitation teams to make sure there's awareness with our GP practices. And it's also really pleasing to see the work Lancashire and South Cumbria Foundation Trust are doing with our BAME communities. And this is a very stark figure. So people with learning disabilities from Black and South Asian backgrounds, heritage, their life expectancy is at 34 years. half of that of other people with learning disabilities. And this is analysis done by University Central Lancashire working with other learning disability charities. And it's good to see that Lancashire and South Cumbria Foundation Trust have been working with voluntary sector organisations like Paradise Gems, local mosques, to encourage these communities to have health checks. So this is a true example where all the acronyms, voluntary, faith sectors, the trust has come together to start making a bit of a difference. But that is a figure I think I had to look at twice because it's very stark. So just to conclude, I think we've heard, and I sort of held my questions back from Andy Knox's paper, we've seen 21% more attendances in UEC, 147,000 more attendances per year, getting on increases year on year. And that will continue if you don't do anything about it. Hospital emergency admissions via A&E has increased by 27.5%. GP appointments just from last year increased by 3.4%. Our waiting list on elective is double the size that what we had before the pandemic. 240,000 people waiting compared to 120,000 people waiting. Even with all of that, our performance compares favourably with national and northwest position, but there's a lot of work to do. And just reflecting on what's been discussed today, the transformation plan, I think, is a must. Otherwise, next year we'll be saying is further increases and the pressures are increasing. So we have to shift our attention, shift left and around prevention, community, and everything we've heard today. If you do that at scale, will help us. And Aaron's point, what gets measured gets done. And I've been reflecting when Andy was talking, there's potentially a framework there around the roadmap. And it's not about performance report, because what I'm doing here is sometimes duplicating what Aaron and Chris and other people are doing at their boards. Yes, I think it's beneficial to look at it as a system level. But if we could start looking at metrics, let's say Tracy looked at respiratory. Respiratory is the biggest reason for admission for over 65s that are admitted from A&E. And with circulatory disease, 1/3 of our patients. So what can we do? What kind of metrics that we can put in that we can start turning a dial on these things and look at all of the people around the table that can contribute towards their metrics? Sakti talked about children and young people. Yeah, in Blackpool, 40% of our young people leaving school are overweight or obese, and that's getting worse. So could there be a metric? It's not going to happen overnight, but we need to start somewhere. So I think we need to really start looking at a shift around what we look at as a board, because our board report is mainly focusing on the provider performance, but there is, I think, a need to look at this maybe somewhat differently. So I'll pause there, but I think really good performance, when I say really good performance, compared to what we've been asked to deliver, there's absolutely a lot to do here. 12% of people not being seen in 4 hours is not good performance for the people who are not being seen. So is comparable to the Northwest National Region, but I think there's a lot more we can do in this space. Thank you.
Thank you. Thank you very much. Aaron.
Thanks, Chair. We talked about the next steps for ICBs and the blueprint work earlier. What's writ large in that is the expectation for a system to have really highly skilled intelligence, business intelligence and health analytics. I think Asim's just demonstrated Route 1, what that can bring to a conversation. So I just want to thank Asim for the way that he triangulates and builds reports that can be quite anodyne sometimes when it's just on the metrics. It's a highly skilled piece of work. That's what I just wanted to recognise that, Chair. So you could look at that report and think, well, aren't we all doing well? You know, huge amounts of demand growth and yet performance remains stable, but it comes at a huge cost. So £164 million more than we get just this year, and the health and wellbeing impact on colleagues in all parts of the system who face that demand every day is not sustainable. So I think we're back to the conversations we were having earlier around kind of what's the priority of the board, what's the things that only the ICB can do that can start to shift the metrics that really reduce consumption and demand, and what are the things that other parts of the system at place or other partners should be getting on with and delivering. Because I think the blueprint's a really great opportunity to really clear the decks and go, right, okay, this is a very powerful, very influential infrastructure of the ICB, and I think in the blueprint, if we can align some of that analysis with some of the roadmap, we can really start to turn the dial.
Agreed. Thank you. Saxi.
Thanks, Chair. Speaking on Aaron's point, I think there is a real opportunity to shift our focus from activity to outcomes as the ICB transforms into a strategic commissioner, and looping back to the blueprint or the roadmap that we've just discussed. My eyes just automatically went to page 109 on this, and I've been advising and been on provider boards and here for longer than I can count. But that column, I just want to draw your attention. I'm just curious about that column, ICB Commissioner in month. It just jumps out. The very things that we know will keep people live longer or reduce admissions, like smoking at time of delivery, smoking, childhood vaccinations, early diagnosis of cancer, flu vaccination, proportion of people who we need to treat with hypertension to target, are all sort of marked red. And I just wondered, is this in spite of us measuring things aren't getting done, or is we are improving but not quite what we set out to improve, and really just bring back the focus on outcomes, and these are things that can't be done just as an ICB. It needs providers, it needs partners, it needs working with communities differently, and it will, more importantly, help us save money and improve outcomes. So I'm just curious about how, as a board, we zoom in on not just the diagnostics and demand, which is in itself a challenge, but keep coming back to actually what are the things that we are measuring that will make a difference and are evidence-based and will lead to reduced demand and cost. So I'm just curious about what that column shows, and it doesn't look like we are improving, but is that true?
I think what that column shows, Sakti, is huge variation. Yeah. So what you see there in the hypertension and diabetes, there's different colours. Some are green, some are red. And this is what I talk about, that when you see that from a performance perspective, you say one area is performing better than the other. So hypertension identification in Blackburn, and there's a lot of work, and Andy might be able to talk about this more eloquently, around some of our South Asian sort of population, has been challenging in terms of getting them compliant. There's also a lot of data around where we think the prevalence should be, so what is under-diagnosed. So there, and we've got a lot of figures around that. But I think what you're saying, Sakti, we need to really bring this to life. Yeah. So there's no narrative around this. In the performance report is a table, but what I'm trying to do with this as well is these are the kind of things we should be focusing on, and what we'll start seeing is not just an health intervention, is an intervention from many of our sectors. Yeah, so that's so I can't give you, is that good performance or bad performance? I think it'll be a mixture, and that's what you see. Variation is a full grid of colours there, from all the way from light green to dark red. But that's our variation of what's happening in our population. Thank you.
Thanks. I've got Chris and then Andy.
Thanks, Chair, and thanks, Asim. Just 2 points, if that's okay. So, inappropriate out-of-area placements are at 2. That's 2 too many, but that is significant improvement. And, you know, 2 people are the majority of people are receiving inpatient care in Langston, South Cumbria within patch. So that's really, really good, and a lot of work has gone on between our teams, ICB with Craig's and local authorities to get to that. The bit I wanted to pick up on is the learning disability health checks, and nationally there's a lot of talk about parity of esteem with mental health and physical health, and yet despite a really important target, I feel, being dropped nationally, this ICB has decided to keep a spotlight on it for all the reasons why Asim said, and I think that just shows parity of esteem in action, and that's this board should take some real assurance from that it is really levelling up and seeing healthcare as one, and not seeing the differentials between physical health, mental health, learning disability and autism. So I just wanted to note that and thank Asim for raising that.
Thanks, Chris, and very good to hear about the OBS. Andy.
Yeah, thank you. And Asim, brilliant report and brilliantly presented, as Aaron said, just superb. So two points, if I may, Chair. The first is, I think, I want to echo and enhance what Aaron said about, and going back to the previous point, of what is the role of the ICB and the changes we need to make within healthcare, what's within our gift, and where do we need to work in an integrated partnership way at place or at neighbourhood to actually drive change, and therefore strategically commission, in line with some of the stuff Craig was talking about earlier, to make sure we're shifting resources into areas where things are more of a struggle. So let's take the hypertension example. Actually, if you look in places like Fleetwood right now, 88% of the population treated to target. Less than 50% in Barrow. So we've got quality and variation issues. One box won't tell us. It won't even tell us the variance within South Cumbria, but we do look at that data much more drilled down at the Population Health Board, which feeds into the Quality and Outcomes Committee. So the governance has been really strengthened in this area. This data is helping us strengthen the governance and flow it through and make sure the people who need to take responsibility for these different pieces are actually beginning to take that responsibility, and we're moving to action rather than just information, which is really important. The second thing is, and I think it's going back to Tracy's point and Sakti's point earlier in the debate around the roadmap, which I thought were really helpful, is actually what is it that matters to our communities, and how do we ensure we're really thinking strategically as partners in place and in neighbourhoods about outcomes. So yes, it's true that people are treated poorly for hypertension in Barrow right now. And we've got other metrics which are much improved, and so we're doing well in some areas and not so well in others. But actually, when we think about obesity rates in our children and young people, as Asim just highlighted, partly it's an incredibly complex issue, and we often go to behaviour change programmes which have very poor evidence base compared to, say, for example, really strategic commissioning and sugar taxes and the things that would actually make a massive difference in that community, and where licensing happens and all kinds of other bits and pieces. But really, if we looked at children and young people in Barrow or in Blackpool, we shouldn't just be concerned about 40% obesity rates. We should also be concerned about the fact that only 13% of our young people in our poorest communities, 13%, are leaving with passes at GCSE English and Maths. When we think also about the mental health crisis within our children and young people as well, we do need to have a far better, strong, integrated strategy around what on earth we're doing for our children and young people. Yes, best start in life, but actually working radically differently with our schools around how we're going to help our children and young people have a real sense of purpose and vision and what it means to grow up in Lancashire and South Cumbria, not just so that they're healthy and well physically, but so actually mentally and academically they're thriving. And so I guess what this data does is it calls us all to account for a bigger, better vision for our children and young people and for all our population, and asks us all to hold a mirror up, no matter what organisation we work with and for, to say we've got to do better and we've got to work better together, because actually right now there are too many metrics where we're just letting our communities down. And I think what actually this new roadmap and this new blueprint for an ICB allows us is to put this with razor-sharp focus back onto the agenda for all of us and ask us better questions, not just about how we're going to admire the data or the size of the problem, but how we're going to turn our plans into actions that actually make a difference. And I think that's what we're heading towards.
Sam.
I guess just looking at what we've seen on the board today, we've got a budget that we approved before of almost 5.4 billion. We know the deficit last year was significant, and we've got 164 million of deficit support to break even this year. We've got increasing demand, as we've just heard, and part of our plans for taking costs out and delivering the plan last year was, a lot of it was around the UEC, which we've just heard has gone through the roof, and it's no wonder we couldn't achieve the plan. We've just heard about worsening outcomes and increased costs. And I think when you look at all of that, this is absolutely a symptom of not having everything in the right place. And this is why it's such an opportunity to get right. And I just wanted to make that point because I do think this next stage, I know I said it before, is going to be key to get right because we've just configured it. It's in the wrong places, and we need to get the focus in the right places because it will drive this out. Because what we are deemed to have with 5.4 billion is enough resources for the types of population and the deprivation even that we have. The allocation formula says we've got enough. We're just not using it in the right way. So this is a real opportunity.
Thank you, Sam. So I think we've got a number of areas that are all interlinked here, aren't they? So we've got the model ICB, we've got the transformation roadmap, we've got the performance report. I'm not going to nail down some dates, but I think we need to see, the board needs to see iterations of those, but in an interlinked way. Great, thank you. Okay, we now move to the finance report, month 12. So this is last year's outturn, isn't it?
Yeah, yeah, it is, Chair. So I'll be brief because it relates to last year. Yeah, this is the financial position for 24-25. So just a few headlines. We outturned with a deficit of 130 million. But if you kind of build back the 175 million pound deficit support funding and 50 million winter surge, we actually finished the year with a 355 million deficit, which I think was a point you made, Chair, in your opening remarks, the scale of the challenge. That was 180 million worse than the plan that we set. I suppose looking on to be slightly glass half full, the position was significantly worse than this. I think it was at least 40-50 million pound worse than this before Christmas. A significant amount work was done in kind of quarter 3 and particularly into quarter 4 to improve run rates. So we exited last year in a better position than it looked, and that we've brought that into this year. You can see already the run rates at the start of this year are better. Just moving on to capital briefly, we had a plan to spend 140 million. We did underspend by 2.4 million. That was unfortunate. I think we tried to land this on a pinhead. I think there was some late rebates came into one of the providers that caused them to underspend, but it's kind of we are. It's difficult to land that kind of scale of capital programme. And I suppose just asking the board to note the contents of the report, and I suppose just to put on record, this is subject to audit, so all organisations are being audited at the moment, but I touch wood, I'm not hearing anything coming out of the audit, so I assume the position won't change. Thank you.
Thanks, Stephen. Any questions for Stephen? No. Okay, we will move on then to governance and assurance, starting with the audit committee, escalation and assurance report. Jim.
Thanks. A couple of items mentioned under alert that I'll briefly mention. In last year's external auditors report, they mentioned about our financial planning arrangements. This time round, it's likely that they are going to comment on the domains of financial sustainability and governance, but we'll only know that in a couple of weeks' time. We had the audit report on all-age continuing care. We've talked about this earlier today, but the audit report that came in had 19 high-priority recommendations. They will be being built into the action plan that's being developed at this moment in time. And the other point I would mention is that under alert, we make reference to outstanding audit recommendations and the number of freedom of information requests that were delayed, and basically we need to, possibly, if we can, sharpen our act up on both of those items.
Thanks, Jim. Thank you. And we did bring these because we wanted to bring them sooner to last month's private board as well, those aspects. So I would, again, in public, reiterate the importance of those. Any questions for Jim? No, thank you very much. Quality assurance processes, Sarah.
Yeah, thanks, Chair. So the purpose of this paper, it's come on the back of a couple of questions over a number of board meetings. So the purpose really was to inform and assure board, and I'd pull out 3 key points. One was to draw people's attention to the National Quality Board, which has a number of documents which guide the system, guide ICBs on how to do quality surveillance and how to manage risk. And we do comply with that guidance, just to assure board. Clearly, some of this may or may not change as ICBs and the blueprint, but at the moment that is the guidance we have to follow, and we do. And then it was really just to note the plethora of both informal and formal means by which the quality team work with the providers, and it's all providers, it's not just the big trusts, we cover all of it, and with our regulators and with NHS England. And the formal route for reporting that surveillance up through to board is via quality committee, and that's also the route through the alerts at which we would escalate anything of concern. And the last point is really around specialised commissioning, because we'd previously been asked. So there's a diagram in the appendices which hopefully demonstrates to board members how the specialised commissioning team do their surveillance of quality. It's a very, building on some of the points earlier, it's a very, very small team. They were going to transfer and be part of the hub. Obviously that's not going to happen now, but that won't change how they operate that surveillance across specialised commissioning services across the North West. So I'm happy to take any comments or questions.
Thanks, Sarah. Any questions for Sarah? No, it's helpful to have had this, actually. I think it answers a number of things that have risen over the last few board meetings. Thank you. Okay, the final report is concerning matters considered in private board meetings. There are, I think, still 3, which still demonstrates the amount of work that's been undergone, but I would hope that this report will become shorter because there'll be less done in private. Deb.
Thank you, Chair. So the report presents a summary of the key matters considered within the private board meetings. As you've just referenced, the board has met in private on 3 occasions over that period. There is a summary of focus from each of those meetings included under section 2, and I think we can see that a number of those have actually come into the discussions today, as we would expect, and that the report's for noting.
Thank you. Thank you very much indeed. Any comments, questions on that? No? Okay. So we come to any other business. Does anybody have any other business? No. Fine. Items for the risk register. A quick confab between Deb and I. I don't think there's anything new for the risk register. I think it's worth noting, though, that the board did have quite a comprehensive session on the risk register and the board assurance framework. So that will come back to the public board in due course, but I don't think there's anything additional out of today's agenda unless anybody wants to correct me. No. Well, thank you. Thank you, board members, for some really good discussions, and thank members of the public for seeing it through. I look forward to seeing everybody in 2 months' time. Thank you.
Thank you.